This conference will now be recorded.
Hey guys, I'm Cheryl O'Neill. I'm the administrator at Spanish Cove in Yukon, Oklahoma. I've been here 20 years. I am the administrator. I didn't start as the administrator. I worked my way up. I am an RN, and it was just the next feasible step for me. And it's really great. You guys are going to really like what you do. Many days it's hard, but in your heart, you'll feel it. And this is JACKI Dunlap. She's an RN, and she's my director of nursing over skilled and long-term care. So she has a big wealth of information. She's been here 15 years. So I think that's the one thing that makes Spanish Cove different, is that most of our management staff have been here 7 to 25 years. So we kind of have a family here. So let me see if I can start this slideshow. What we're going to talk about today is about administrators' roles and also working with the DON, how important that is for you guys to get the best nursing for your residents. Does anybody know how to start the slideshow here? I'm trying to get my pages to move.
You may have to hit your space bar or something to advance your slides. I don't know.
It's not advancing, sorry. I've hit the page down, I've hit. Nope, it's not touch screen. That should be the vote.
You have to hit escape and get out of it. Or maybe Philip can tell you what to do because he's our IT guy.
Okay. It worked yesterday, but I don't think I tried to get it to go.
Yeah, it worked yesterday.
Yep. But like I said, my IT person downloaded a new program.
All right.
How about those arrows in the bottom left-hand corner?
In the left-hand corner where?
They pop up, I believe, if you move the mouse or whatnot. They were appearing on my screen on the bottom left-hand corner. Yeah, there they are.
Thank you, Philip.
You're welcome.
I am very challenged in the IT area. Course objectives. This is what we're going to go over today. To understand the role of the administrator and the resident care. It's basically going to be, we're going to cover all the nursing and some stuff that you probably will never use, but it'll kind of give you an overview of the body of a resident and what to watch for so that you can help with your nursing, to make your judgment, to make your final call on, because you really are going to be the one that is the deciding factor in everything that goes on in your facility. So it's important that you trust your nurses. It's important that you trust all your managers in each department. It's a big job. We're going to describe, I've covered most of this. And then the tools that will help you. It is a partnership. Now we're going to talk about I got it. The IT guy on here helped. No one is immune to aging, and we're going to go over some of the life expectancies from around the world. I'm sorry that you guys have that screen on the right side, but anyway, this is life expectancy and was what it was in 2018. And I compared this to like 2014, and almost every country that I show here, they all went down, not even a one person, or 1 year. It wasn't quite a year for everybody, but every one of them went down just a little bit. And of course, women live longer than men, just by a few years. The proportion of people 65 and older increased from 4% in 1990 to about 16.9, and I can't read the year there, 2020, increased to about 21%. So, and we expect that to double in 2030. We're going to have adults in 2030 who outnumber the amount of children we have in the world. So that's a thought. That's job security for you in your nursing home, because these people are going to need somewhere to go, because there's not going to be children that take care of them anymore. There also is different types of aging. Not everybody's the same. So you have a young, you have a middle, and you have an old. And old, 85. Man, I've got 99 and 104 over here that we take care of, and they get up every day. So to me, they're just not that old. Maybe it's because I'm getting older. Why does this keep going away? I'm sorry, guys. That thing at the bottom keeps going away on me. Okay, the normal aging. And I can't read that, Jackie. Minus disease encompasses numerous changes in the body system. In 2015, reveals normal changes occur in both structure and function of the organs, age or old age, old age, as they say, the most vulnerable, which I think everybody knows that. We're going to talk about the normal aging process. I don't know if anything's ever normal, especially these days. Everybody ages different. Everybody has different health factors in their background, and so everybody's going to really age different. But the nurse can play the vital role in improving the care. Educating the family and staff is the key to your success and getting the optimal goals, hitting your optimal goals. Jackie, you want to add to that, any?
I mean, you'll just see that aging is very individualized. We have some that, you know, I have one that's 102 right now. The only thing wrong with her, she can't hear, and her body, you know, is giving out on her, but she's all there mentally. And then I have some that are 75 that, you know, their mind is completely gone and they depend on us for everything. So definitely remember that aging is an individualized process.
Yeah. Okay, the importance is to differentiate between normal aging and then when you start to see pathological changes in the body or the brain. There's lots of risk involved, but the important thing is to get your interventions correct on your care plan. Your care plan has to start immediately upon admission. Okay, we're hopefully gonna give you some knowledge of the aging process and the role nurses play. But what you got to know is that age plays a vital role, just like they're saying, and educating the families are key to providing optimal care. I'm sorry, guys, this is boring. If you were in person, we would be a lot more exciting. Okay, effects of aging. You lose your vitality.
Some do not.
and some do not. Remember that, Jackie's correct. Everybody does not age the same. I mean, we've got, like I said, we've got 65-year-olds that would act a lot older than our 90-year-old. So it just depends on what kind of life the person's led, how many diseases they're predisposed to. The skin is very fragile, as you probably know. You will find all kinds of little skin tears, bruises, and scratches, just because they will just barely knock something and the whole skin will slide off. It ages with a person, so it gets very thin and fragile. But one thing you need to know is that a skin tear, a bruise, a scratch, anything like that is an incident report. It has to be, you have to complete that form, the incident report, which I'm sure you've had that class already. But every little thing that's a change in the resident that you, especially when you don't know what happened to cause it, is an incident report. And you need to investigate what could have caused that skin tear, whether it was during a transfer and the aide did not notice it, or possibly the person was up toileting himself and hit the doorway. You just never know.
And if you don't investigate and find the possible causes, or know that your DON has a process in place to do that, any injury of unknown origin is a report to the state. And some people, believe it or not, lawyers, families, the state, a skin tear is not just a skin tear. Some people believe it is a staff-inflicted injury. So make sure that, as the administrator, you have a good team in your QA nurse, in your DON, your ADON, or whoever is underneath you that knows the process of the critical pathway of investigating all those incidents. And so sometimes with the changing of the brain and the changing of the skin and aging, some residents are more sensitive to cold because they don't have as much adipose tissue. Some residents do have plenty of adipose tissue, but their skin is still real thin. And there are a lot of people, a lot of the aging population that have balance and coordination difficulty, but not everybody. I still have a lot of residents that walk freely that, don't fall. They just have dementia. So eventually with that disease process, that'll change, but that's not always with everybody. And not everybody has difficulty seeing. I have residents that can still read a newspaper. Your nursing staff should be doing assessments. We do ours weekly, and in part of ours, we ask them to read a normal menu or read a paper so we can see if their vision is changing. And also with falls or anything, that's one of the things we check, is to make sure they can see.
And also if they wear glasses and you find a bruise by the glasses or something like that, that's a bruise, that's an IR, and it's considered a head injury. So you have to report it to the state. I've been known to disagree with that, because a bruise could be from the glasses, not a fall. I don't know how that's traumatic to the brain, but they consider that a report to the state because it's a head injury. You want to cover these?
So a lot of residents, you'll notice as they get older, their mucosal membranes start to dry. So they have dry, itchy eyes. Sometimes they have dry mouth, which can lead to difficulty in swallowing. And a lot of that also could be a side effect of some of the medicines they're taking. A lot of older, especially Caucasian and Asian women, have osteoporosis. So they have a lot of loss in bone minerals and bone density. So they're at increased risk for fractures when they fall. Lung capacity decreases, and that's just because your diaphragm and stuff can't expand as much as you take deeper breaths as you get older. And incontinence, I have a lot of residents that are incontinent. Some of them may have a little bit of stress, but not completely incontinent. And I don't have residents, not all my residents need to go to the bathroom at night. So we have residents that sleep all night without urinating. We have a program where we, push water all day and we stop at 7 o'clock. And then if they want water, we'll give them water during the night, but that way they get a better night's sleep because they're not getting up to go to the bathroom. But not everybody is incontinent. I know that is a stigma for getting old, but that's not true. And not everybody has hearing loss, so please be careful how you talk to them. You don't want them to be like, I'm not deaf, because you're trying to be loud. And I have residents tell staff that all the time.
Or they may be blind and you yell because you think they're deaf too.
Yeah.
That's a big one. And you just, like Jackie said, you can't assume everybody has a hearing loss. As the administrator, you need to understand the basic principles. It's going to be important. So when your DON comes to try to solve a problem with you or get a decision, because you are going to be the ultimate end all, except for the CEO, as far as the nursing departments go. So you want to make sure you're familiar with the human body, some of the processes and some of the disease processes, and just general aging process. How are you guys going to ask questions? Yeah, they are. If you have any questions, is there a place for you guys to raise your hands? There we go. There's some. I just found the chat box. I'm sorry, guys. I am really challenged here. My button to move forward disappeared.
Just so you know, we participate in plenty of Zoom meetings, we just never post them.
Yeah, we've never done this, as you can tell on here. So, Jackie, you want to talk about chronic versus acute illness, the difference?
Okay, so chronic pretty much means that this is the illness that doesn't go away. So this is your COPD versus, like you have pneumonia and it goes away. This is also like chronic kidney issues versus you have a kidney infection or a bladder infection that's treated with antibiotics and goes away. So the chronic illnesses are the ones that you're going to see a lot of increase, I think, as people age with diabetes and stuff like that. Those are going to be the chronic illnesses we see a lot. Exacerbation is where, say someone has COPD or, hypertension or CHF, and then they go into getting their lungs full or whatever. That's an exacerbation that can be, taken care of with some antibiotics. And once the antibiotics take care of the exacerbation, then they just go back into their chronic phase. So there are several systems in your body that, as an administrator, it is useful as a DON for me personally, just that Cheryl was the DON before I was, and she is a nurse. So it's easy for me. So I've never had it any other way. I worked as an LPN here and then worked my way up through my bachelor's, and that's how I got here. But so I can't imagine what it would be like if I didn't have Cheryl, who's a nurse. So this is where it would be useful for the non-nursing staff to kind of know the basics of these systems. So when the DON comes to you, you do know what they're talking about. But so the cardiovascular, that's one of the main things, and pulmonary, those are the two big things we see a lot here. I don't know about other communities, but we, and the men have a lot of BPH or prostate problems, and we don't have a lot of UTIs here, and we don't have a lot of Foleys or anything. So that's kind of, I guess, maybe the other places they do.
And isn't it true that your star rating, there's some quality indicators that with urinary UTIs will cause you to go down?
Infections and stuff. So you're really going to want to make sure that you also have a person that takes charge of that kind of stuff, like especially with your renal and your bladder system. So the oropharyngeal and the gastrointestinal, those are just your mouth and your all the way through to your anus. Muscular, sorry, her screen. So muscular, skin, and their nervous system and cognition. Those are the major systems that you need to know in your immune system.
Oh, gosh, you guys can't see this, can you? It says, they can? Okay. I have even smaller wireless device that gives me access to thousands of books. And then the older person says, I have a library card. That's so true. That's so true. Your employees are going to be at a different, they're different than your residents as far as what they believe is important. One of our biggest problems, and I'm sure everybody has that, is your CNAs and staff, floor staff, you'll find them on their phones a lot. There's different ways to handle that. We usually what, Jackie, give them a warning or?
Yeah, we give them a warning first, and then we know that there are single mothers. There are also, we have high school students that I have kids that are that age too, and I want to be able to get a hold of my kids. So we encourage them to give their family the nurses' desk numbers. We have 4 nurses' desks, you know, if there's an emergency, so they can call. But we give them a warning first, and then we have a progressive discipline that we always follow in our policy. So after your written warning, then you get a formal warning and a meeting with me, which is not always lovely. And then after that, then we take your phone. When you come in, you have to leave your phone with the nurse.
And you'll be surprised how sneaky they can be. They will go hide out in a vacant room, or they'll go in with a resident like they're visiting and spend all their time on the phone instead. Your residents will be your best source for that. They like to tattletale. So especially if it's somebody they're not that fond of. So you just, some places, I believe they take the phones and check them in at the beginning of the shift, and then they can have them on break. We haven't done that. Right now, hiring, I don't know if you guys are aware, but hiring is really, really hard. People are not searching for nursing home jobs. People are not searching for a job, period. A lot of what we're finding with the staff is, for a while, they were making more money by staying home and collecting unemployment. And as you know, that's a big downside to hiring CNAs and CMAs. If they make more money sitting at home, a job as a CNA and CMA, they're the hardest jobs, they're the most labor intensive jobs you'll find. And most of the time it's very, very thankless job. Make sure you're praising your staff. Make sure you're giving them kudos. Make sure the DON is also present on the floor. She has, she's involved with everything that goes on the floor and knows what's going on, whether it's something that is gossip on the floor. Somebody always tells, is that not correct?
They all have my cell phone, so my cell phone goes off all the time. I have an open door policy. I give rides to people to get to work. I pick them up if something happens outside of work. CNAs and CMAs are so hard to find. You need to foster the loyalty in the good ones. And don't be afraid to get rid of a bad one, because that's how you're going to keep your good ones. Okay, this stuff is, to me, the boring stuff.
Yeah, very boring. Just get the overview.
So I go through it kind of fast just because there's no reason the administrator needs to know this in depth, because you have nurses beneath you that know this in depth. So
And trust them. They
yeah,
do.
we do. So the cardiovascular system, you know, it's powered, we all know, by the heart. It pumps the blood through the body, you know, through all the vessels and back through your lungs and back through your heart to clean it. It's what keeps your brain, your kidneys going. So those will be a lot of the problems that you come across, though, as you age, is the CHF and the right side and the left sided heart failure. So that's one of the major things we see here.
Yeah, and isn't it a lot of times pneumonia and heart failure? Pneumonia will be diagnosed with actually heart failure.
Mm-hmm. That does happen. So as you age, the stuff that we eat affects our arteries and, you know, our veins. So there's a lot of thickening of that, and there's a lot of occlusion. So like they get clotted, and, you know, they have to go in there and clean them out. You, a lot of the left side of your heart shrinks too. So it can't, pump as hard or as fast, and that's where sometimes they go into AFib. So there's a lot of people that are on blood thinners from, the weakening of the heart and the stuff that goes along with that. A lot of things are the valve problems too, like the valves wear out. I mean, imagine a normal heartbeat is 60 times in a minute. Well, if you're 90 years old, you've lived a lot of minutes and your heart's beat a lot of times. So always make sure, your nurses get checked off annually on skills, because you need to know that your nurses know where to check for pulses. We check our staff off frequently, and I'm on the floor, my ADON's on the floor. We, can still take care of patients. We still toilet patients. So we can definitely tell when changes are happening with our patients, and a lot of the things we see are related to feet, or, the wounds are to the lower part of the body. And a lot of that has to do with your veins are no longer strong enough to pump the blood back up to your heart. So that's when you get a lot of arterial or venous stasis ulcers in the lower part of the body. That has to do with the heart.
Yeah, I got a question.
Yeah.
I've heard you all say a couple times that the DON needs to be out there on the floor, and I get that. I'm currently doing an internship, and what I'm hearing on the floor is that the DON is so busy with paperwork stuff, they don't have time to be on the floor, and they need to be the assistant DON. I mean, is that a common practice in most facilities, or because I'm coming from pediatrics to geriatrics, so it's completely different.
Well, I imagine it is different at other facilities than ours, just because I know no different. I was an LPN on the floor here. So I'm very good at delegating my paperwork tasks. Anything that can't be delegated, I of course do. But my patients and my residents and my staff, they need to know who the DON is. So we've been deficiency free for 3 years. And when our state survey team comes in here and I'm on the floor, my staff is not scared of me. They continue their business. I still feed residents. So if I'm on the floor and they're busy, my staff has no qualm telling me, hey, I need you to sit down and feed. And your state surveyors notice that. So if your DON and your administrative staff only come out when state's there, they're going to notice that. And your staff is not going to appreciate that. So 67% of my CNAs have been here a year or longer. 72% of my nurses have been here a year or longer. So I think it does matter. Like, your DON needs to be involved with your staff and your residents.
But one thing, probably a lot of the different, I don't know where you're doing your internship at. I don't know if it's Medicaid, Medicare, or if it's a CCRC, but we have staff in place to help Jackie, and not everybody has that luxury. But we also are a CCRC in a life care community. So we have independent living, we have home health, we have assisted living, we have long-term care, and we're going to have memory care. So you see, we have nurses in all areas. And so sometimes they can help each other out. But if you can, make sure your DON has a real strong ADON. I don't put my input on who Jackie hires as her ADON, because that's really not my area for her. It's somebody's going to be working under her. So I let her manage her own department. That's the one thing, administrator, you need to do, is let your department heads, you've hired them for a reason. They know what they're doing. Don't micromanage them. And also build relationships with them so they can trust that you're not going to jump down their throat if they come to you with a problem, or you're not going to override their decision. Sometimes you have to, but very seldom. Most of your DONs know what they're doing, unless you got a brand new one and you need to get her trained well. So in some of the Medicaid, Medicare homes, I know those DONs and them don't have probably a lot of extra staff to help with the paperwork. So you're going to have that, but if they could at least take maybe a coffee social with the residents when we're able to visit each other in person now, I mean, a little bit later.
So I have a list of that I've shared with several facilities that are, for profit or whatever, that we're real big on sharing the stuff that we have. So I've sent them just like a daily DON task that I do. because I haven't always had all the staff I have, but I am very fortunate. So I know that other facilities, the DON does a lot, like a lot of other places, the DON is doing like the infection prevention and, you know, doesn't have a lot of staff or has staffing issues, so she's having to work the floor. And I'm very fortunate that I don't have to do that. So, but even a 5-minute walkthrough in the morning or in the afternoon when you change shifts, it makes a huge difference. So
Even if it's just to tell the staff hi and see how they're doing, they like that personal touch and personal, you caring about them as a person. As the administrator, like I said, I've worked my way up. I've always given out my cell phone number. I even have my desk phone rolled to my cell phone. I'm lucky here, people don't abuse that. I can't say in all homes that would be that way, but our residents here, we have them for their lifetime normally. So you build a relationship when they're in independent living, and then you continue that relationship all the way through their aging process. So I wouldn't say they abuse my phone. Do I get calls after hours? Does Jackie get calls after hours? Do we get calls on weekend? Yes. But it's not anything we can't handle, or we would, you know, we would not use our cell phones.
this again goes with cardiovascular, just the aging process of the heart is, you know, in line with the body.
Skip one, didn't I?
Okay.
Okay.
So I'm not sure that the major cause of death is cardiovascular. We have a lot of different causes of death for our residents. You know, cancer is very prevalent, you know, complications of diabetes. So I don't know. I know that cardiovascular is a huge thing, but there are a lot of other things. Dementia is a huge thing right now. People die from dementia frequently.
Oh, sorry. Keeps getting over there.
And of course, the atherosclerosis is like the buildup of fat deposits on the side, and they usually have to go in through the femoral artery and clear that out. And sometimes when they get a lot of buildup in their veins, you'll notice they get a little more confused, and it's because they're not getting a lot of blood to their, especially if it's in the carotid, and they're not getting a lot of blood to their brain, and sometimes their confusion can clear up a little bit once that's cleared out. Aortic stenosis, that does happen too. So the ventricular part of the heart that's trying to pump the blood to the rest of the body, when the aorta starts to get stiffened or isn't as elastic as it used to be, then there's a lot of resistance on the blood flow, which can increase the blood pressure and just not perfuse the blood as well to the rest of the body. Yeah, symptoms, you know, you'll notice that they wheeze a lot, or they're difficulty breathing, or, you know, they're dizzy. Sometimes they just feel like something's sitting on their chest. So, and it's different for everybody. Some residents don't complain at all ever, and then you're like, okay, their oxygen's 82, what's going on? So you got to send them out sometimes. But if it's a chronic disease, I think they learn to live with a lot of that shortness of breath and dizziness that goes along with it. Coronary artery disease, yeah, that's a lack of oxygen, and it can cause tissue death to the coronary arteries and places on the heart, and that can lead to a lot of the MIs that you see. We don't see a lot of MIs. I don't know why. We just don't. I don't know if we're lucky, but we don't.
And sometimes if they have an MI,
If they have an MI, it's a major
it's a major one, and that's about it.
Because a lot of us are DNRs.
We'll cover the symptoms.
Now, the symptoms, a lot of the cardiac symptoms you'll notice are the same no matter what the disease process is. You know, chest pain, shortness of breath, dizziness. A lot of them, like upon exertion, like if they're exercising or walking to the bathroom or whatever, then their oxygen drops, or they get even more dizzy or more short of breath. And a lot of them accompany the swelling in the feet. You'll notice like swelling in the feet, and that's just because there's not enough blood perfusion, or, you know, the fluid in this interstitial space, intertissue space just builds up down there because it's not allowing it to pump out.
Here's just some more symptoms.
The PVD, we have seen several residents with PVD that end up having like ulcers or, wounds to the bottom part, shin and down. And a lot of that's just because the blood does not perfuse or move back up to the heart quickly.
Quit working. Philip, what am I doing wrong?
I think your mouse is right clicking instead of left clicking sometimes.
And of course, the cold feet, the numbness, the ulcers or the infection, what I just talked about. So, and also if they get a skin tear, we've noticed a lot, like say they hit their shin or something on the foot pedal of the wheelchair, that will turn into a huge wound with someone that has PVD. So, and a lot of our nurses sometimes put that as a stasis ulcer, when really it's not. It's a injury that kind of turned into that because it couldn't heal.
What are some of the symptoms?
A lot of them just have like pain in the feet or they're numb in the feet, and you have decreased fetal pulses, so they can't feel their pulse very well in their feet.
And their fetal, in their extremities, sometimes will be cold, maybe blue, because of decreased blood flow. I know it.
And of course, in hypertension, it used to be 140/90 was the normal blood pressure, and they have lowered that to 130/80. A lot of our residents that are on blood pressure medicine, that's another checkoff. You'll need to make sure your nurses and your staff know that you need to take the blood pressure before the blood pressure medication is administered, not after, because after, of course, it's going to come down because that's the purpose of the medicine.
And when we enter the orders, we put it in that way, so that the staff knows they have to have that blood pressure before they can give the med.
We also put parameters on all of our blood pressure medicine on when to notify the physician, and every physician is different. We're a little bit different. We don't have just a house physician. We do have a medical director, but our residents are free to choose whatever doctor they want. So I deal with about 16 doctors. Hypertension, it can be controlled with medications, diet, and exercise if it's essential. If it's secondary, sometimes that's due to an underlying disease process, or like my son, he's 18 and he has hypertension, and his is hereditary. He has a issue going on, so he's had it from the time he was 13. So, and Cheryl over here, she has hypertension, but she exercises all the time, and hers is hereditary too. So sometimes even medicine and diet and exercise won't, contain the hypertension or keep it low. So
I think I took my first blood pressure pill when I was 30. So I knew I was set up at that time, but that's why we want to try to keep the residents as active as we can, and a proper diet.
Congestive heart failure, that's the biggest one we see. It's just, it's progressive weakness of the heart muscle. I mean, the heart beats so many times in the 90 years that they're alive that the elasticity and the ability to pump the heart really hard is no longer there. So that's when you get the blood can back up into your lungs. And right-sided and left-sided, they have different symptoms, and they present themselves differently. So on the right-sided, you're going to have edema. A lot of our residents are not hungry anyway, so anorexia is not always just a sign of cardiovascular disease. You probably need to look into that a little more if they're not eating. Constipation, weight gain, shortness of breath is a big one for right-sided. And then the left-sided, they have that, it backs up into the lungs. So they have that chronic cough or wheezing. And we've noticed sometimes we send residents out when they sound full, and they'll be like, oh, well, they just have COPD. And that's when, nurses and your DON need to be involved with the resident. Like, we get a report every day. Our staff sends one in our email that's in our EHR, and it CCs me and my ADON, so we read it every day. So if we notice the change in the residents, I'm like, okay, they went to the hospital, but they don't have COPD. We need to call the PCP because it's heart failure. It's not COPD. So this is where your nurses know and your residents can advocate a little more, because shortness of breath is not always lung related. It can be heart related.
And loss of weight is not always related to that. I would start with the mouth and search on down. You got to check dental work if they're having a loss of weight. input, and then we would get into the bigger issues. Cerebrovascular disease. A lot of people don't understand, not you guys, but the public does not understand that cerebral vascular disease is related to the brain. So it's about the amount of blood flow you get to the brain. And it's missing the second note there, which would be the signs and symptoms of a stroke or a CVA would be slurred speech, blurred vision. You can have one side of your body that turns numb, or you can no longer, you're leaning to one side because you've lost that on that one side. Those are pretty dominant features, wouldn't you say, Jackie?
Mhm.
And then it can cause permanent damage. If you catch it quick and go to the hospital, there's lots of things they can do now. But the older people will require a lot of therapy to get better. And then some of them can't tolerate that. So you do the best you can with what you have. Can you guys see that? The bottom says, what fits your busy schedule better, exercising 1 hour a day or being dead 24 hours a day?
And those are the basic things that your nurses are going to do on a cardiac assessment, except you're not going to run like an EKG normally. We do have someone that comes in and does it if our physicians order it, but it's not just like a normal thing. And those are things you should be checking your staff off on for competency for when state comes.
There's a little bit of humor in here. Pulmonary respiratory systems. Well, we all know that that provides our oxygen, but it's real important that we remove that carbon dioxide. It's able to repair itself after an infection. Lung conditions, common cause of death in the older people. Didn't we cover that a little bit earlier?
Yeah, I mean,
It really is.
Vascular and lung conditions are what we see the most of, and dementia.
Yeah. So we're getting into the pulmonary changes now. A lot of it, you'll see decreased muscle strength. You have a stiffer wall. It's harder for them to breathe. It's harder for them to get a deep breath.
Sometimes that has to do with the way they sit. So
Yes.
like if they have kyphosis and they're hunched over, or they constantly lean to one side or the other, they're not going to be able to inflate their lungs as much. So their oxygen saturation may always be in the 88 because they can never get a full breath.
And a lot of times they struggle, but they compensate, and then you got to watch their CO2. Because if they're not taking deep breaths, their body will just compensate. They're sitting in a chair, they're not usually putting out a lot of energy if they're not feeling well. And then the body just slowly gets used to that, but there's usually a deeper problem.
And they do have a decreased cough reflex also. So say they aspirate a little bit. A lot of residents, as they get older, they silently aspirate. They're taking a drink and you have no idea, a few drops of it are going down into the lungs until all of a sudden they have a fever and their lungs sound gross. That's because they have a decreased cough reflex, and the little hairs or the ciliary and the lungs don't work as well. So they can't keep the stuff out as easy. And their epiglottis doesn't close as quickly.
And talk about COPD.
COPD is the one we deal with the most here. And of course, a lot of doctors now, or that we've seen, they just lump all you know, lung stuff into COPD. I don't know why, because emphysema is different than just regular COPD. But asthma and chronic bronchitis are usually lumped under COPD. And a lot of times if you have COPD, increase in oxygen is not always the best thing. If they're statin at 92 with oxygen on, they're good. Like, there's no reason to shoot for 96, 97. If they're at 92, they're good.
Yeah, they probably haven't been at 96, 98 forever.
If you're, you know, you're not trying to overcompensate and blow too much oxygen, because then their CO2 will build up, especially with the emphysema. And of course, with COPD, there is no cure. And a lot of times people are on nebulizing treatments or inhalers. And when I was started as an LPN here on the floor, people would have like this white like rash or something in their mouth, and that is from not rinsing their mouth after inhalers or nebulizing treatments. That causes thrush in their mouth. So that's another thing. That's another teaching thing. Because the COPD itself is terrible. I mean, they can't breathe. But then when your mouth hurts, then you're not eating, and you're not one to take your inhalers. You're not one to brush your teeth. So always make sure your nurses know. And we have that as an order in our inhalers to rinse mouth after. So the emphysema is different. It's not, it builds up your CO2, and they can't blow it off as well. And you'll see a lot of pursed lip breathing with emphysema. So it looks like they're, you know, breathing in and out of a straw. When I was an LPN on the floor, I had staff that accidentally left oxygen off of a resident. And as a teaching moment, I had them breathe through a straw for 3 minutes with holding their nose. And so they're like, that's so hard to breathe in. So you have to like teach the moments. You'd be like, okay, so that's how the resident feels when you guys, you know, don't pay attention, or, you know, they're struggling to breathe and they're scared. Because a lot of people with emphysema, they have high anxiety because they cannot breathe. So that was a teaching moment that I used for my staff, and the staff that I worked with at that time still work here, and they do not leave oxygen off of residents. We don't see a lot of lung cancer here. I don't know how that is other places. I've only had to deal with lung cancer here once in the 15 years that I've been here. It was a horrible death, because I can't imagine not being able to breathe.
It is. I had two, I think, prior to you coming here, and one of them we had to join her chest. She had a pulmonary tube in, so we had to suction out her lungs once a day, I think it was, with this automatic thing you hooked up. She had a tube. So, and then every one of those deaths have been really hard to witness. They just seem so difficult. So I want to talk about a little bit is, one thing is always make sure your residents are comfortable, whether they're in the last dying stages or just in life in general. They've had a long life. Make sure they're comfortable. That when you're dying of lung cancer or any kind of pulmonary disease, it's just they struggle to breathe. And it can sound really horrible with their breaths. And the dying process, it does. You get that gaspy breathing at the end. And it's just as long as you're keeping them comfortable with your pain meds or your anti-anxieties. And a lot of times if they're having difficulty breathing, a lot of times it causes anxiety. So it's not so much the pain, it's the anxiety of trying to catch a good breath, and they're suffocating. So just always know it's not always pain, it can be anxiety. And I think that's a lot of the reason we make people with hospice at the very end, you make them comfortable with morphine and Ativan or whatever it is. But you'll have the stubborn ones that don't want anything when they're hurting. But at the end, it's be compassionate, make sure the residents are comfortable, and hopefully you won't have any family dynamics where they say, don't give her anything, because we've had that too. And that's not pretty at all. To auscultate your lungs, you're always going to see how deep they're breathing, the rhythm. Is it rapid? Is it really like slow every 10 seconds they're breathing? Access the rate. all your nurses are going to do this. They're going to listen to lung sounds. They need to know what good lung sounds are and what bad how their lung sounds sound, and compare it to their normal. Like, you always want that base normal on everything. Right now we have baseline temps, number one, because of COVID, but we always have their baseline with blood pressure and pulse, that way, and temperature, and that way we know if it's normal for them or if there's a change. You have to know what's normal for that person. Okay, here we go with the COVID. I just added this. You can give it to me. Okay, I added this because we didn't have any of the COVID in here. So I don't know about you guys, but it sure changed our way of living here. It's not very, it's hard for it to be resident centered right now. This is when you're going to count on your staff to make sure you're doing the phone calls, the FaceTime. We do FaceTime twice a week.
Well, no, we have some residents that get FaceTime every day. So we have residents that get FaceTime every day. Because we have a lot of families that were coming every day, so the residents were used to seeing their loved one every day. And we noticed come, I don't know, end of May, that after we had stopped visitation, that we had a lot of residents that just started declining rapidly, and it broke all of our. So we went out and got iPads, and then we started FaceTiming. We started with once a week, but then we, had several that requested to do twice a week, and now some do daily. We did open visitation 4 weeks ago every Wednesday. So every Wednesday, families get to come and meet with their loved ones for 30 minutes, and we still are continuing FaceTime too. And it's made a huge difference.
And I don't know how many of you have got an internship going on during the COVID or not, but if you do, you've probably seen the drastic changes. You'll see the drastic changes in the residents and just the way we do things.
We had a lot of weight loss because, they couldn't do communal dining. So that isolation of them eating in their rooms, even though if they needed assistance feeding, we went in and helped feed them. It was not the same as sitting with their friend, or with our dementia patients that they have a pattern now. They walk to the dining room, they walk back to the room. They had a really hard time. We have lost several residents. And I'm not so sure a lot of it wasn't due to a lot of the things they went through with COVID. So it's
not
very
due
sad.
to the COVID disease,
No.
but due to
Because
the
we don't have any residents that have COVID, and we also don't have any staff that have COVID. But
currently.
But I can't imagine how it changes the other homes. Like, I know that there are some homes that are having to test twice a week, or staff that are taking care of COVID positive patients. I can't imagine the mental toll that's taking on everybody, because just us outside of work, like, my kids are tired of masking up. I can't say that I'm a fan of doing it all the time, even though I know it's the right thing to do. So I think the mental anguish right now with the staff and the residents is at an all-time high with all of this COVID stuff. We all know that everybody's at risk for it, but the highest risk are the residents in the nursing home. That's where the most deaths have been. A lot of people don't necessarily practice all the social distancing and stuff outside, and that's the thing that scares me the most about the government demanding we open up, because we know for a fact people here in our town in Yukon, we don't have a mask mandate. So when we go out, like just to Walmart, half the people don't wear masks anymore. So I can't imagine letting those people in here to visit their loved one and then getting their loved one sick. I know you have to weigh the pros and cons, like, is it worth their mental anguish of not seeing their loved one? But sometimes it is, because we have some residents whose families are not ready for it to open up. They do not want their parent to die from COVID. They would rather talk to their parent on the phone than their parent get COVID, because we opened it to the public or to families to come in just because they don't want to talk just on the phone. So that's kind of a catch-22.
And then any visit that we have, and I hope you've seen the opening guidelines we got from the state health department and CMS. I don't know if you have, but it all depends on your county and what's going on in your county on whether you're yellow, orange, red. And then actually they found that 8 out of 10 deaths during this time have been due to COVID has been people 65 and older. That's why it's so dangerous. It's not so much the COVID that gets them. It is the disease process they already have. It exacerbates, and many of them just don't make it.
I do know with the COVID, the 65 and older, there's an increased risk for, even if they get COVID and they're asymptomatic, there is an increased risk for blood clots, actually. It's an actual thing. Blood clots is an effect of COVID, and we actually had one resident. The only resident we admitted him. We admitted that resident with COVID. We did not get it in here. But embolism, and the hospital said that they have noticed a lot of that with people that have tested positive for COVID, and especially in the males over 65, that they are getting secondary to COVID blood clots. So it's really, they told us to watch for skin rashes over areas in the legs and the arms, because those are the capillaries starting to form small blood clots before big blood clots happen. So there's a lot of information still out there about COVID that not everybody knows, I think.
And just remember, as far as COVID, there's not a lot of relaxation that a nursing home can provide. They have to follow the rules. It's step by step. You can't leave one area, whether you're green and you have free visitation, and then a week later you're in yellow and you have to shut, or red. Maybe you jump to red, but you have to close down the visitation. And so we've kind of erred on the side of caution and done it slowly so that we're not starting visitation, then stopping it, starting and stopping. You know how that would be so hard on the residents. So
that's where Cheryl, the administrator, having a good relationship with her helps, because she is taking some of those calls for me from families who don't understand that it's not our choice, that we are just having to follow government regulations. And after I've had my fill and my ADON has had my fill, Cheryl steps in and will educate the families again. So you'll find that a lot of the times the families don't want to hear from your DON, they want to hear from you. They want to hear from the person in charge.
Yeah, and a lot of times we end the conversation okay. Sometimes we just have to agree to disagree. And for me, the basic thing is they want to go see their mom. They don't care about the other people who don't want them to come visit their mom. But the thing is, they don't have the right to come in here and possibly infect all the other people. That's not their right. So they can come take their mother or father and take them home with them. That's been an option from day one. But nobody's done that. Nobody wants the 24/7 job at home. But they do. They're so lonely. So lonely. I've seen a lot of lonely people. When we first started, we couldn't do anything. We couldn't do activities. The dining was the big thing, as Jackie said. So just always remember the heart of it and try to get across to families the importance of keeping everybody here safe. So, and you'll see that by these statistics, you'll see that it is nursing homes that are getting hit the most. And that's because we're communal. But 40 to 42% of deaths in nursing homes. That covers the whole, that's 40 to 42% of everybody that gets COVID is in the nursing home or assisted living. But we're nowhere close to what Canada is. Canada is just, it's rampant there right now. In Oklahoma right now, we're getting ready to hit 80,000 cases.
We're also getting ready for flu season. Our IP told me yesterday that, Tuesday, that in August was 3 Oklahoma hospitalizations for flu already in August. So we're going to make sure our staff and our residents all get their flu shots as soon as possible too.
That's one thing we've learned. You need to stay on whoever your provider is if for your flu shots for your residents. We ordered ours in January and we're still waiting on it. We should have been top of the list, but it's every year it's this way. Every year you're waiting on your flu shots. We have the ones for employees, but of course we need the high dose for the residents. So make sure whoever is in charge of that at your place that they order early and we plan early, because you'll still be waiting. This is how in my day we used to do it. Only we didn't have Pinterest, any of that. So I don't even know what some of these are. They're so way past me. What's Foursquare? Went too far, didn't it? There you go. Now we're going to get into urinary, and because that's basically, you're going to see a lot of urinary tract infections. It doesn't just mess with the urinary system. In older adults, it messes with their brain function. You might see some abnormal behavior. They may seem like they've had a mental status change.
They may pee in the trash can.
They may pee in the trash can or on a planted pot tree.
Or the air conditioner.
Yeah, we've had it all happen here. Usually we start having the staff put a hat in the toilet, look for the color, have your staff look for odor, anything that's different, and if there's a mental status change, check the urine first.
Here we have an antibiotic stewardship, which is mandatory from CMS. So we do not automatically check for UAs when someone's confused. We push fluids and we monitor urine for 24 hours.
We always do that just in case, but and a lot of times those are clear and they have had a mental status change, but you always need to make sure you're on the right path there. And like I said, this is just showing you kind of the normal pathway that urine goes through your body. It does remove a lot of waste from your system and breaks down, and it helps regulates the amount of fluid in your body. It's also important over time to watch this, we call it CMP, a lab, to watch your electrolytes. Make sure, you'd be surprised how much even a high sodium will change a mental status.
Low sodium, you'll have residents falling like crazy and you're like, what in the world? That has not happened. And normal is like 135, they'll be at a 133 and all of a sudden they're falling all the time.
Yeah.
So it changes a lot.
Sodium really messes with you, and potassium messes with the heart rhythm. So that can be very dangerous. Here's some changes, age changes related to your renal function. Everything just gets a little bit older. You lose that elasticity that's in your bladder, and therefore then you don't have the muscle tone and you don't have the capacity to hold a lot. They'll need to void a lot because they're not emptying their bladder normally, right?
Or they sneeze and they cough and, you lose some urine when they do that. Or even when they use the muscles to stand up, it's a little bit stress incontinent happens.
Yeah. One of the major things that I see happen with the residents that I see in all our areas is they all complain about getting up at night. So I haven't found a medication that works well for that yet. I hope they come out with one soon because it does interrupt their sleep. The sleep interrupts their mental status. It's just a cycle.
And you do have residents that we try to double void the residents we know that can't empty their bladder all the way. So you will have residents that go to the bathroom, but then they still feel like they need to pee. And so then they'll have a lot of residuals left in their bladder. And sometimes you just have to straight cap that to get the residual out, and then learn to double void the residents. But like I said, not everybody gets incontinence. Oh, a lot of men have BPH, so their prostate enlarges, and so they can't really use the bathroom, or you'll notice when they're going to the bathroom, it starts with like little spurts, and they can't get a solid stream, and that is one of the signs of BPH, which that makes them an increased risk for UTIs because they can't empty their bladder, and for having residuals after they use the bathroom, they still have urine in their bladder.
And it's pretty painful for them when their prostate gets enlarged. It's hard for them to sit. It's just hard for everything. Here's some implications of changes. Would be decreased renal function and complications. So it puts you at a risk, like we said, for complications. A lot of times you can have adverse reactions to drugs. Depends on how your kidneys and everything are filtering the blood. Remember, the kidneys filter your blood and gets all your electrolytes regulated. So you're also at a risk for overload on the heart. And then, like we've been talking about, you have urgency and incontinence and nocturnal polyuria, which is getting up many times at night, and then that increases your fall risk. And Jackie, I think, has hit this well. I mean, urinary incontinence is not, everybody doesn't have it, but many do. They may need help with the care. They may not. And some of them, you will have difficult circumstances where some residents think that they're still able to take care of that, and it just causes more dirty urine, and they're not properly caring for themselves. So that's where your CNAs and your planning and your assessments all work together in that nursing department.
And we do not, here, part of our antibiotic stewardship, we do not treat UTIs until it has shown that it's grown out something. We don't let our physicians start a broad spectrum. So we follow our antibiotic stewardship to a T. We have a great IP. She's been a nurse here with me for 7 years, and she's great at her job. So I'm lucky that I have that. But as soon as someone, a nurse or a CNA, tells us that they think someone has a UTI or any kind of infection, they are to call us. So they call me or Tanya, and they walk us through what they saw, and then we give them instruction. They do not immediately call the physician, because we have had to talk to all of our physicians multiple times. We only really have one now that won't listen, but the rest have, jumped on board. And we've sent them the federal regulations stating that, we have an antibiotic stewardship and a program. So we don't just start broad spectrums. We do sensitivity and medicate based on that. And we don't do, like, if someone has, we think they have pneumonia, we don't just do an antibiotic. We make sure we get a chest x-ray, and that it's a positive chest x-ray. Because in the past, doctors would just order antibiotics whenever. They're like, oh, they have a cough, here's antibiotics. So here's a runny nose, here's a Z-Pack. So we don't allow our physicians to do that here.
Yeah, a lot of times you have to let the doctor know it is a regulation. You have to follow, you will be dinged on it. So it's very important that we don't feed into this over antibiotic use. This is why they did that, because
So we don't have quite that high of residents that get on antibiotics. I'm pretty sure our antibiotic use is really low right now. We use the McGreer's criteria. Our nurses are taught it on higher, and then they check up on it every year. We actually pull it up in our EMR and our EHR, and it's there so they can see what symptoms the resident needs to have before they can do the next step. So having your staff follow your policy will help you with your antibiotic stewardship.
And if you look at these numbers, the 70%, the 40 or 7, you could see we're overusing, way overusing. And then what does overuse of antibiotics cause?
C. diff.
Which is a nightmare.
Yes.
It's an isolation. You have to be in isolation. The resident has to be in isolation. It's just
And it's painful for the resident. It increases their risk for falls. It's just increased for dehydration and increased for wounds on their bottom. It's increased risk for another UTI because it is terrible. C. diff is terrible to have.
And I hope you guys are familiar with C. diff. Not because I expect you to have nursing, but it's something that affects your nursing home or your living areas, because it affects the residents so much. It affects the staff. It's a risk to pass it from, like if you have a caregiver goes in and takes care of a C. diff patient, maybe they aren't using proper procedure in between and they pass that stuff around. It's just not a good situation. It's an awful situation for that resident. Dehydration, fall risk, like Jackie said, getting up and trying to go to the bathroom. It's just a very uncomfortable situation.
And I know right now with C. diff, everybody, is pushing the alcohol-based hand sanitizer, use it, use it, use it. That will not kill C. diff. The only thing that kills C. diff is soap and water. Antibacterial soap and water. You must wash your hands. Alcohol-based hand sanitizer does not work.
Yeah, and you need that basic knowledge. Like Jackie mentioned earlier, there's an IP. We have an IP, which is an infection preventionist. It's a requirement now. It's a reg, and we're going to talk about the infection preventionist later on this afternoon. So we'll cover that, but just know you do have somebody who has the training to answer some of these questions for you. She knows what kills C. diff. She knows what will get rid of the COVID bacteria floating around in the air. She knows all that. Oh, here you go, C. diff. Not only that, then you build up a resistance to your antibiotics, and when you're having pneumonia or something like that, it won't work. Jackie, tell them about colonization, what you look for.
So colonization, so say it's a colonization of a UTI, so a bacteria in your urine. So with colonization, it's always going to be present, like a small amount, but if it's less than, for us, if it's less than 100,000 in your count when they run it through the lab, we do not treat unless the physician is adamant, because we have some residents that always show positive, and that's because they are colonized. So that bacteria is always there.
What do you look at on the lab result to know whether it's colonized?
There is nothing that says colonized.
Okay.
It will look like a positive UA. You have to know that resident, the history of their UTIs. You have to know the history, and if it's growing out the same bacteria all the time, you have to discuss that with your IP and the physician, and you have to deem that she has a colonization. And then you should put that in their chart. And they no longer recommend, even with the antibiotic stewardship, people used to put people on a low dose of macrobid all the time, like 100 milligrams of macrobid daily. They don't do that anymore. Or trimethoprim. They used to do those, just as a preventative for people that have colonized bacteria in their urine. They don't do that anymore. One of the reasons that you don't want to overuse antibiotics is because you can get MRSA real easy, because it is resistant. I mean, that's the thing, is it's become resistant. And they also have a VRE. So they just don't have MRSA. They have other now superbugs that have become resistant because we've overused penicillin and all of the stuff in the broad spectrum. Others we already read there.
Okay. Overview.
So the whole intent of the antibiotic stewardship is because you do have certain doctors and certain nurses that are just automatically, this is what's going on, get them some drugs, get it in them, get them better. And then they found out over time that, that's not always right. Because we would have residents in the past, before this was mandatory, we would have residents in the past, we would treat their UTI with the broad spectrum that the physician gave us. And then 2 weeks in, they're completing the antibiotic and they still have symptoms. They're still burning when they go. They're still having frequency, and come to find out it was resistant to that the whole time. So we had to change the antibiotics. So that's why they started doing this, because physicians were just throwing antibiotics out there like Tylenol and ibuprofen. So they had to do something to make sure that the whole population as a whole does not become, and you'll notice doctors, if it's a good doctor, a lot of doctors don't just prescribe antibiotics anymore. If you go in and you have a sore throat or whatever, they're like, oh, it's viral, no antibiotic needed. Or before, they used to just give everybody antibiotics. So that is the whole point of it, is so we don't develop these superbugs.
Everybody want to take a break? Let's take a 15-minute break. We'll be back here at 10.
This conference will now be recorded.
I apologize for this being so boring. In person, me and Jackie are much more sparkling. So we'll probably get through. This is our first time to do this on Zoom or GoToMeeting or whatever we're doing. And it's a lot faster than it is in person. So you guys will get out early today. Well, my boxes aren't coming up now. There we go. So we're covering the renal, and we're still on the urinary system. These are your normal, this is the filtration rate that the urine, your kidney and bladder and all that starts to clear out the urine and filter your stuff. And so these are the different levels that you'll see. So we always watch this because a lot of times you'll see on diagnosis that they have stage 3 kidney disease or stage 4. And at stage 4, most of the ones I've seen, they do get dialysis. And that's something you allow for your facility. You get them to and from dialysis. And also if they're on SNF, you have to make sure that happens. Here's your assessments. You're going to cover all the lab, and you get that GFR, your filtration rate. We check for everything Jackie's already basically covered. You're going to watch your electrolytes, dehydration, if incontinence is new. These are nuanced things, like if they have urinary urgency. I don't know if somebody's not on mute, but here's you another joke. It says, I don't know if it's cut off on the right. I think it is. We all be heavier as we get older because there's a lot more information in our heads. No, I use that. So I'm not fat, I'm just really intelligent. Is everybody getting some feedback? Okay. Caller 1, I don't know who that is, but they're not muted. Here we go. This is your breakdown of food, how it goes through your body. It starts in your mouth with digestion. It always starts in your mouth with chewing, and the enzymes in your mouth start breaking it down. and it goes through the whole body system that way. Every little thing has its own job to do, whether it's your liver, your gallbladder, pancreas, any of that stuff. Everything has a part and all that, and then it comes out in the end. Here, I mean, it's basically what we talked about is that you put the food in your mouth and then you push it all the way through. Swallowing is a complex mechanism. So swallowing is a big thing for you to watch out for in your older people, because they may have dentures that don't fit. They may have a broken tooth. They may have a toothache and be unable to express that to you. So this is things you watch for and then getting speech therapy involved in. If you have a client who is losing weight and the staff is noticing that they're not eating much and that it seems to hurt when they chew or when they swallow, you always want to get a speech eval. We use speech a lot here. It makes a difference in, they can also work with memory. I don't know how much success that is, because a lot of times when we get them in the nursing home, they're going to be past that level, probably previously already used it. But sometimes they can make memory books and it works out well. At least the resident has memories and can recall those when they're sitting with the family and discussing things. And a lot of times, even on that, is the families will think, well, they're able to carry a conversation on, they're doing better. They remember me, they remember what's going on in their life, but it's not. It's a memory they have. It's not in the here and now. Here's your healthy weights for your BMI. And you will have a dietitian who on every admission will do an assessment for dietary, what we need to look at as far as the diet. Where they are on the BMI. Are they overweight? Are they underweight? Or are they just right? One thing I found in our little women is that a lot of times they come to the nursing home and you'll see a little bit of weight loss, and we immediately jump on it with a supplement or something like that, depending on their BMI. So once they start having a weight loss, I see a lot of them like that. They want to be small again. Do you find that, Jackie?
And with the BMIs, they're evaluated the whole time they're here. Our dietitian and dietary manager do an evaluation every 3 months in conjunction with their MDS. And we do our weights monthly, and if there's any significant weight loss, which we consider to be a 3-pound weight loss, we notify the dietary manager and physician and family. So that way we know to get supplements on board or not.
And then we've also seen residents that outgrow their clothes every few months. So the food that you offer there, it can be pleasing, but it's not going to be pleasing to everybody. Some people, they always want their own cooking, or they want, their family's cooking. And so it takes them a little bit to get used to that. And then also we see people fatten up because all of a sudden they're getting 3 meals a day. We're probably at home alone. They were probably lucky if they ate 1 meal. And you'll find we find a lot of spoiled food in refrigerators for home health. We have our own home health, and so we go out to the independent living, and you'd be surprised how many refrigerators are full of old food because they want to save everything. There's going to be something good on it. They'll pull the furry stuff off and they'll eat the good stuff. So we have to watch that a lot, or you'll get a lot of stomach poisoning. How is age related to our swallowing process? Well, it decreases those strengths, and that's what you see, and that's sometimes speech therapy will help with that. Their gastric gases will just decrease. So you don't get a lot of emptying. You don't get a lot of absorption of the nutrients. So
Their mouth is dry. Their mucosal
Yes.
membranes get so dry. A lot of people, that's a side effect of blood pressure medicine. So when you're not producing a lot of saliva or mucus to chew, that puts them at increased risk for aspirating or choking, because especially with bread and stuff like that, if it's not moist, they can't swallow it because the motility of their esophagus doesn't move as quickly or as freely.
that's right. We already talked about the loss of teeth. I mean, you'd be surprised how much that affects their eating.
Because let's just face it, if you have teeth problems and you are requiring a soft diet, a lot of the soft diet is really like ground meat or, you know, soft vegetables, and that's not very pleasing to the eye. And if it's not pleasing to the eye, then you're not really going to put it in your body. You're not going to put it in your mouth. So we do see a lot of weight loss if residents don't have teeth or their dentures fit improperly, or they just don't want to do anything about their oral health. Those are the residents we see that lose the weight the most.
And you will be required, and as the administrator, have a dentist contract with the dentist that has to come out every so often to be present. We call them for people who need, he will try to come out here and he will fix what he can. Sometimes we have to take them to the office. So that's a big thing. The other thing Jackie talked about was medication. We all know that depending on the medications we take, you can get stomach distress, you can get diarrhea, and a lot of times it's just upset stomach, so they don't want to eat. And then their stomach gets empty, which makes it even worse.
They are at increased risk for GERD. And so like your ibuprofen and your NSAIDs, they really do cause a lot of gastric distress. So that's where you'll find you'll need to, a lot of the times, like if we don't have someone already on a preventative that's on something that can cause irritation, then our pharmacist will find that when he is checking monthly. And he will send a pharmacy request to the doctor asking for like Protonix or Prilosec or something that kind of coats their stomach to help with some of that medication irritation.
So here's the assessments that your nurse should be able to do, and that's always listen to the bowel sounds. If somebody has, let's say they have a medication that causes diarrhea or upset stomach, or a lot of times it can cause constipation. So we always need to make sure we're listening to bowel sounds, make sure that motility hasn't stopped in the stomach. You have to watch out for blockages. So all this, everything in your body leads to something else. So keep that in mind. That's why we treat the whole person, not just a disease.
One of the things we do for the bowels here is our CMAs run every day they run a bowel report, and it will tell them who has not had a bowel movement in 3 days, and we automatically give something for that. So that way nobody goes more than 3 days without a bowel movement. So we know,
Is that a standard order you put in?
it is a standard order that we put in here. And that's because, you know, a while ago we noticed, I mean, this was years ago, we noticed there were several impactions, and, you know, those aren't easy for the resident to get out. So in order to quit having those, we decided that we would monitor the bowels. And so we started doing that probably in 2012. So we monitor the bowels closely and run that report. The CMAs give it to the nurse if anybody's on the no BM report for 3 days, and then when they get a laxative or suppository, whatever their doctor ordered.
And I just looked at the chat room, and Terry Minsky said that also wanted to say that some of the patients on dialysis do not produce urine. And that is so correct. Everybody is so different. And that's why covering all this nursing stuff, it's probably overkill. I don't want you to think that when you're the administrator, you could be the DON. That would be hazardous. We don't have time as administrators to cover that. So and here you go. That's why we lift on 3. You have to communicate.
There's going to be a problem always. I mean, for some reason, that is a problem between departments, between one shift to the next, between the CNAs and the nurses, between the office and the nurses. I mean, you can think you're communicating as well as possible, but for some reason, there's always something wrong.
Yep, somebody misses something and then you feel like a failure because you let the resident down. And nobody wants that. But so try to treat your other department heads, treat them with respect, listen to them, always listen. Don't try to talk over them. Just listen to what they have to say, and then you guys can discuss it. You don't always have to be right. So that's something you need to know. We're all wrong occasionally. We may think we have what's best interest of the residents, and sometimes you do. Sometimes you do. But a lot of times you have to step aside and let your department heads do their thing. You hired them or you absorbed them when you went on as administrator. So it's so important that you build relationships with your supervisors, especially your DON, and work together. No one ever needs to be the heavy hand. Occasionally you do if it's a final decision, but take as much as of it you can, but don't overload yourself. It's a big job. What you're getting into is a big job. Here's your skeletal system. You can see all the dang bones, all the tendons, everything that your nurses are concerned about. We'd be here all day to cover every system, so we're hitting it large. And again, you do not have to know all this stuff, just know the general principles. You want to talk about the musculoskeletal system?
Okay, so
About muscle mass
yeah,
loss?
they lose a lot of muscle mass as they age. And so say they're doing therapy, when they're doing therapy after they've had a lot of falls and stuff like that, they are creating muscle memory. So as your muscle mass decreases, that's sometimes hard for muscles to, get the memory going or get the amount of mass muscles some people need to continue on to the level of that the therapy gets them up to. So it's not always easy for the patients that are their age to do rehab with the musculoskeletal system that they have. They do lose a lot of lean body and they do lose a lot of bone. And so the age that we take care of, or the population that we take care of, is mostly Caucasian in this building. And so we do have a lot of osteoporosis because we do know osteoporosis affects mostly Caucasian and Asian women. So that is a lot of what we see. And so when they do fall, you do have a lot of skeletal changes because you have the fractures of the hip or the pelvis. We don't really, we do see lately, we've been seeing a lot of back issues with, say, the neck or the spine because the discs are degenerating. And so you see a lot of kyphosis.
What is kyphosis?
Kyphosis is like the hunching of the back, and a lot of that's due to degenerative disc disease. So the disc in your spine are just like collapsing. So you see a lot of that. We have seen a lot of people getting the cement in their back lately. We've seen them for skill. So I guess it's happening more and more in the middle of the age. We don't really see it in the old age, but the 75 to 85, we do see that because they still want to live full lives.
And a lot of times with the skeletal changes, you'll see a big height difference. Usually by the time we admit them, into the nursing center, they have already shrunk, either due to bone loss or some kind of injuries in their backs. So you will see they're not their usual height. So you'll want to make sure your nursing staff is doing those measurements correctly on the height.
And we teach them not to go off the hospital paperwork. We've told them to lay them on the sheet and mark it at the top of their head and at the feet and then to measure it. So.
And it works out well.
Yeah, so that way the resident doesn't have to stand still, or you just lay them down and measure them.
One of the hardest things when we get a new patient is they're coming from the hospital and they don't want to get on the scales because they're dang tired. They've just been beat up by travel. They've been in the hospital bed for a week and they're tired and want to go to bed. But you got to make sure you get that starting weight. You don't want it to be the hospital weight, and some nurses will put the hospital weight. It's accurate. The next week, when you weigh your patient or your resident, you're going to see a weight difference. But you don't know if it's an actual gain, an actual loss, because nobody took that admission weight on your scales.
We do a weight daily times 3 days on admission, and then weekly times 4 weeks.
Yep. Is that complete vital signs?
Well, we do 72-hour charting after admission. We do complete head to toe on each shift, including vital signs for 72 hours.
And what all this on the muscle changes, it affects the way they move. It affects the mobility of the joints. It's just hard for them to get around sometimes. And always watch for that PT referral, because that's one thing you can do to help them get stronger, and maybe it's a balance problem. So we do a lot of PT when we can. We use our resources. That's something you need to make sure your nursing staff is doing, searching out for those things that will make the resident better, and maybe so they can enjoy their life better. Decrease those risk of falls, decrease confusion, decrease all that. Get them up, able to do more as far as activities, whether it's to go see their loved ones, but maybe somebody who couldn't get out of the car in and out before can now, with therapy, with OT and PT, maybe you can get them where they can get in and out of the car. They can shower on their own. There's a lot of improvement that can happen with the people like this, but it's going to take all different areas to build their strength up and balance, and physical therapy and occupational therapy will also help.
And make sure you use your restorative after PT or OT to maintain that level of function.
Yeah, that's something you're going to need in skilled nursing and in long-term care, is you have a restorative aid, and you need to make sure they go to school, get trained for that. We've had a lot of CNAs that we have moved to restorative aids. They seem to be good at that area, or sometimes it's just doing more for the residents. If you don't like assisted living, you can't have a restorative aid, but maybe the person doesn't need therapy or they're graduating off therapy. That restorative aid will step in, build a plan of care with the physical therapist, and start doing exercises daily, whatever those are that the PT recommends that are safe for that resident. This is true. I'm feeling this. Some days it's just hard to get out of bed. And the residents, if you've ever watched them try to get out of bed, it's hard. Those bones and everything don't wake up the same as the mind. They don't work in the mornings. And a lot of times just sitting in a wheelchair, sitting in a chair, they can lose that mobility. You've got to do what you can to keep them mobile. It's easier on your staff, as long as you don't have falls, because then that will be a quality indicator on your 5-star rating. The immune system. This one's important right now. Everybody is going to have to fight off COVID and flu. And schools are open. You're going to have stomach bugs flying around because schools are just opening, and we all know that that usually comes from schools and kids.
And let's just face it, we all know that when you're super stressed or super tired and things aren't going right, then your immune system lowers. So I think all of us that work in long-term care right now, we're at even more increased risk because we are under so much stress. Our CNAs are under a tremendous amount of stress, putting on that PPE every day to go in and do showers and come out, and the nurses too. But I feel like, you know, with the immune system being low, we need to encourage our staff members to make sure they're taking care of themselves, because, you know, your immune system is a huge part of, you know, how you feel on a daily basis. We all know infection. Infection occurs when you either have a virus or a bacteria that enters a portal in your body. This can be through the skin, this can be through nasal passages, any orifice that it can be open in your body, bacteria and viruses can penetrate.
And pay attention to your staff. Make sure they're getting enough rest and you're not overworking them. I know we have to watch our overtime here. And right now with the COVID and no people really wanting to work and come in and be hired. Jackie, when you say we sometimes have piles of 10 to 12 applications that we see that we like, we've interviewed them, we're starting them through the process, then 3 or 4 won't show up for their physical, 3 or 4 won't show up for the first day of orientation, and then or the rest of them show up for work maybe a week and then just don't show up. So those are some of the major dilemmas you're going to be facing with the COVID going on right now. I'm not sure long-term care, it's going to be difficult for us to bounce back from this because the public sees all the deaths in the nursing homes. Like we said, 40 to 42% of the COVID deaths are in nursing homes. Staffing is low right now. It's just really hard and difficult. So make sure you're taking care of the people that you have. Make sure you're taking care of your employees. And yourself. Sometimes that's hard because we're doing multiple things. You have to be able to multitask. You'll have several things going on and you just have to watch that. And if you're not good, you're not feeling good, imagine the staff is probably not feeling good. You got to do things that will pump you up and do more with your staff. Appreciate them. That's the thing I want you to know a lot, is that you've got to appreciate your staff. A lot of them need those kudos. They need you on the floor to praise them, or they need you to know their names. That's one of the most important things with staffing, is they want to know that the administrator knows who they are and appreciates them being there. So make sure you share that love. Here's the difference between the immune system, different kinds of infections. Community acquired, of course, comes from a hospital or here or the place where you're at. Is something that somebody gets that's passed around, like COVID. Nosocomial is when the infection is outside of the center, right? And then the majority of the infections are chronic in long-term care communities.
We don't really have a community-acquired or nosocomial-acquired pneumonia. Most of our pneumonia usually comes from aspiration.
That's true. Aspirating because they're not chewing up their food or their swallowing system is broken down somewhere. And that's when speech therapy gets involved. But you're right, you don't want the community acquired infections. It can look bad on you. Make sure that everybody's, washing hands in between residents, all that safe stuff. And your residents will have multiple chronic diseases. It's usually not just hypertension. They may have diabetes. They may have pulmonary problems. They may have peripheral vascular disease. They don't usually have one. They may have one major one, but they're going to have lots of others, lots of comorbidities. Your antibody function decreases. You'll see hormone changes. I don't know that we see that many hormonal changes.
You know, most of the women that come here, they're already through their hormonal changes. Like, we don't even have anybody on hormone replacement. So
you just don't see that in this age group.
the only hormones that we usually see is when they've chosen to do hormone therapy for cancer versus chemo.
Right. And then they always have a polypharmacy. We've been really good about cracking down on that. We try to get rid of the meds that are probably not important for them, because every one of them will tell you, every resident will tell you, I didn't take all these medicines before I came over here. And so really watch that. We don't want to add a lot of unnecessary drugs, and we want to remove drugs as we can.
So when you do your MDS every 3 months, it's a good idea to go through your meds then, because you have to have your care plan. So you go through the meds then with your IDT team, and our residents' families are super involved, so they're usually at the care plans, and so are the residents. So you go over the medicines with them then, and any resident or any medicine the resident wants to get rid of, we then notify the physician that we had the meeting, talk to family, we're getting rid of these medicines. Plus, it's a good idea to just send those over to the physician every 3 months and ask them if there's any medicines they think we can get rid of at this time. And then it shows in your charting that you are continuing to do that. And when state sees that, when we do that, they're like, okay, that's a great idea. One thing about the immunity is that if you have someone that has a catheter that you are capping, you are there at high risk of getting an infection. As much as you want to try to be sterile, you're opening that port of infection frequently. And just remember, anybody that has a wound, that's a port of infection as well. A skin tear, anything that opens the skin, that's a port of infection.
It's true that vaccinations decrease the effect?
Because they are not able to build antibodies the way that we are. Their ability to build antibodies has decreased. So that means when we get our vaccines, that's what is happening, is that our body is building antibodies so that, you know, should we be exposed to that virus, that our symptoms won't be as bad. So because they are 65 and older, that's why they get the high dose, because they're high dose, they may get as much out of it as we do our regular dose, because they're not going to get that high rate of antibodies built up, because their body just no longer does that. Oh, and it doesn't last as long. Theirs does not last as long. So I do know that, like, my mother is 65 and older, and she already got her flu shot at the 1st of September. And I was like, I don't think that's a good idea, because it doesn't last as long. When you're older, your antibodies decline faster. Like, you build them up, but then they don't last as long. So I have encouraged my mother, you know, to really watch out for the flu. And I think that's why we usually don't give our flu shots until October.
And you would think this flu season is going to be decreased, just because we're all following safety precautions with the mask and all of that. But I just don't know. I don't know in school if the kids are actually wearing their mask in class. A lot of places they're not. Residents, I mean, people out in the population, they're not following all the mask requirements. So you would think it would be safer. We would see a decrease in flu. And we thought that at the beginning, but now the national stuff is starting to tell us that that may not be true. Vaccinations, you're required as the caregiver in your facility, you're required to give the pneumonia vaccine. You're required to give the influenza. If somebody has a deep gash or they fall and hit their head, they may need a tetanus shot. Maybe it's been forever. So there's still those things we have to take care of for the residents.
Of course, you have residents that have the right to refuse, and that does occasionally happen. But here in our facility, we have 100% flu for employee and residents. All of us get it. We used to have one resident that didn't get the flu, but she's no longer, I mean, the flu shot, but she's no longer with us. But All of ours have had their pneumonia. All of them will be getting the flu.
And every one of these require an order from the doctor and consent from the family, or if the resident is their own POA, it always has to be consented. You don't just get to immunize people and call it a day. Your skin is your biggest organ. I'm sure you guys have heard that over time, but that's our protection from all this stuff. It starts there. And of course, the residents, their skin gets older. It gets thinner. We've already covered all that. It's just, it's less protective as you get older.
We already went over the skin tears, and like I said, once the skin becomes open, then you're increased risk for infection in that area because you've broken the barrier.
Yes.
A lot of residents that are on blood thinners, you'll see this, even the ones that aren't on blood thinners.
Yeah, you see it on, if you just look at your residents' arms, you will see that, that a lot of them will have discoloring almost all over the arm. Their legs probably look the same because they bump into anything. Every little thing they hit just a little bit will cause a bruise or a red spot.
Or even them scratching their arm when it itches.
We've had that happen. But they also, the feeling and the sensation in your skin changes. So a lot of times they don't know they've scratched it. They don't know that they hit anything and bruised it. They just don't, like when they were younger, it didn't happen that way. So they don't recognize it themselves in their arms. But your aides, your CNAs are your big point here. They see the residents in their most vulnerable areas, and while taking a shower or anything like that, they're your eyes and ears. They're your eyes and ears for almost everything. So you got to put some trust into those CNAs, those employees, because they're your bread and butter. Let me check the chat up here. Tracy Carr said, a good DON is invaluable. You are so right. That's why I have Jackie here. I was asked to do this meeting, and I feel like you need to see a good relationship between your administrator and DON, and we do. I trust her decisions. She'll trust mine. It's important that you and your DON work together.
And Cheryl doesn't overstep me unless she feels like she needs to, but she hears me out. Because I do see the residents more than Cheryl does. I'm in it. I'm in the trenches. And I listen to my staff and I listen to my ADON. And so Cheryl, if I come to Cheryl, she hears me out for everything I have to say. If I'm having a problem with another department, she hears both of us out. But she tries not to overstep any of us. She tries to let us figure it out ourselves unless she needs to. And then she will.
And I think Jackie and I, we get tired and we get worn down just like everybody else, but we know we have to be the stronger person. We've got to make sure we take time for ourselves, make sure when you're in the leadership role that you are taking care of your DON and all your department heads. Man, they're the ones that are helping this place run. It's not me. It's not going to be you. It's the people that work in your facility. So it's so important to have good relationships. Know who you're working with, know they're by name. You'll definitely know your department heads, but you want to you need to be a buddy sometimes. Sometimes you have to be the supervisor, but just be able to listen and share your thoughts. Let them share their thoughts and you share your thoughts and come to a decision. Hopefully you could both agree on.
And so my staff always know that I have an open door, but if they have an issue with me that they feel like they haven't resolved and the issue is me, they do know that they can go to Cheryl.
Right.
Rarely does that happen, but if it does happen, then Cheryl will come to me and be like, we got to figure something out. So my staff is 100% aware that, nothing will happen if they go to Cheryl with an issue they have with me. I never hold it against my staff. I want them to be able to feel like they have somewhere besides the DON to go. So that's why Cheryl having a good relationship with the staff in the building, other than just with the department heads, helps a lot, because you don't want the staff on the floor to feel like there's nowhere to go. So like if they have an issue with the DON or another department head, they don't want to feel stuck. So the administrator knowing the names of the employees, I think helps a lot here, because they have no fear to go to Cheryl about an issue that they have.
Did we get this? Oh, we're starting in on diabetes, another fun disease process
We see a lot of that. We see a lot more of that.
in the older adults.
Yeah, we do.
It's not that they had it as children, but they do have it now.
And the thing is most hospitals have like a diabetic protocol, I guess, that everybody, you know, with blood sugars that normally don't even stick their fingers at home come to us with orders to stick their fingers. So that's where you need to get with the 24-hour care plan. We do it in 24. You have 48 hours by regs, but we do it in 24. That's just our policy. So we get with the families and we get with the residents, and if they did not stick their finger before and their blood sugars weren't crazy or anything like that, we call our medical director, and we do not order the insulin. We do not order the unneeded stuff, because we are a standalone facility. We don't have corporate backing. So we don't want to waste the residents' money. But you do see tons and tons of the diabetes now.
And I see it all in the independent living here. We have anybody 65 and older, 62 and older. You will see this diagnosis. You will see it. If you don't know that the residents have it, you will see it in symptoms for sure. We'll see people have fallen a lot because their blood sugar drops. A proper diet, and they don't always follow direction because they don't eat directions as they get diagnosed with diabetes. It's a pretty overwhelming diagnosis. It changes their lifestyle, and a lot of them can get accustomed to it, but a lot of them just don't accept it. And you know, they think they're old and they're going to do what they want, and by golly, I don't blame them.
And we do have that. We do have people that have all the complications you see there. You know, they've got the diabetic neuropathy, they've got diabetic retinopathy, so they can't see very well, and the neuropathy in their legs, you know, where they take the Neurontin or the gabapentin for their leg pain, which, you know, in some of our diabetics is pretty severe. And then they still do not want to change their diet. They still want that bag of Reese's cups by their bed. I mean, they're 85. They feel like they should be able to do that. That's when you would meet with your dietitian, the family, and notify your medical director, and you would change their diabetic diet to regular, and you would chart every so often, which we do with MDSs and our nurses do on their weekly, that we have educated them, the family and the resident. Even if the resident is not able to make decisions, we do continue to educate them on, you know, you're diabetic, are you sure you want that? This is what it can do. And we just modify so that they have the life that they want.
Yeah, so if you get somebody that comes in and has new diagnosis diabetes, but they don't really care, they want to eat what they want, how do you handle that?
So we do the teaching ourselves and the nursing staff, and we also have our dietary manager, our certified dietary manager. She will come in and she will help teach, and then if we need to, we have an actual dietitian. She will come in and teach. So you just chart.
Yep. And we have several out in the independent living currently that we see on home health, and they're the same, only usually they might have a little more mental cognition and able to act as their own POA, but they just don't want to follow. I have one right now who is very brittle. There's 3 times in the last few months that he's been stopped outside of Spanish Cove, and the police have been called or something. He was driving and they thought he was intoxicated. He was at a CVS and he passed out. So it's got several of that going on, but he will not be compliant. I have home health nurses going out to see him in the morning, every morning, to remind him to take his medicine and take his insulin and check his blood sugar. Half the time, I bet 70 to 80% of the time, he's not there. He just cannot, he just can't do it. And he refuses to do it. We also go over there at night for him. Usually we can catch him home at night. but he's on the go. He doesn't want to change his life, but he is being dangerous. He's at the point where he's dangerous.
When he comes here, it's gonna be a hot mess.
Oh yeah, he is. He refuses to come into assisted living. He refuses to come into long-term care, even though that's probably what him and his wife need. But they refuse. So it's a real fine line, and as an administrator, you have to be involved with that. If you are a life care community, you have people going from each stage of life to the next, whether it's assisted living to long-term care. And let's say then they get better, so we move them back to assisted living. These are independent residents outside, and sometimes they refuse to move in, and that's a sticky situation. If they're unsafe and they could hurt themselves, you always have to consider calling adult protective services. You hate to do that because you don't want to run your relationship with that family. You don't want to run your relationship with that resident because you're going to have them for a while. So it's a real tight rope you have to walk there, and you just got to err on the side of caution for the resident's protection. But like I said, he's his own POA. His family is in agreement with the way he is. And, you know, one day we're going to find him probably no longer here because his insulin, he is a brittle diabetic. It takes a lot of insulin to get him to normal. I don't even know that he's ever really felt normal with his blood sugars. He's never been one that managed them well. And so you kind of just have to wade your way through and work through what you can as an administrator. Try to communicate with the family if they're involved. And usually at the end, you may end up having to go ahead and move him into long-term care or nursing home. That may be the only place for him, and we'll get there someday with him. It's not today. I watch it weekly, see how he's doing out there. So we keep an eye on him, and we're able to do that because we're a life care community. But I know a lot of times you're just getting them at the stage of the nursing home, and they've already lived their life, and they usually are doing what they need to do because it's under doctor's orders. Wow. We're still talking about diabetes. I think we've kind of beat that horse.
So a lot of those, though, a lot of times the diabetes is you're going to have them. Their urination times may be a little bit different. They may have large amounts of urine. Some of mine that are diabetic, it's not that they go a lot. They don't have polyuria, but when they go, it is like never ending. You think that, oh my gosh, how did they hold that much pee? And then a lot of them are thirsty. But you'll notice the ones that have dementia that are diabetic, they're not going to ask you for something to drink, but if you set it in front of them, they will drain it like crazy. I have had them in the past drink 2 or 3 glasses of fluids at each meal or anytime you go on the snack because they're not going to ask you, but it doesn't mean that they're not thirsty.
And fluid hydration is one of the main things we need to watch for in a nursing home. Because a lot of times the brain doesn't tell them that they're thirsty. And so you have to make sure you're offering fluids. Make sure your staff is putting the water in the pitcher and they put it in the room, but it's not across the room. Some residents can't get up and go get that. We walk into rooms a lot of times and the call light or the water is it's not within reach for the resident. So that's one thing to make sure you observe because it's so important that they get their fluid. It keeps their urine it helps keep their urine color clear. It helps keep them hydrated. It helps them feel better. They don't have to fight that fatigue. But on polyuria, that's a hard one in this age group. Mm-hmm. Because they already have problems with urinary, as we discussed earlier. So You can see in most of these diagnoses in the age group we're working with, it's just like it's just like there's something. And you never can really pinpoint it. Sometimes you may not, but they all can resemble each other in the end. There's two different diabetics. Jackie, you want to talk about that?
So type 1 is insulin-dependent diabetes mellitus. That is the one, it's a more serious form because your body doesn't really produce enough insulin, so you have to administer. And with ours, the ones that we usually administer we don't have a lot of them, fortunately, but you need to have a good sliding scale from your physician. So as soon as you admit someone with diabetes, you don't have to wonder what your dosage amount will be. You will have a standing order sliding scale from your medical director. That way they don't miss any doses. So if they're getting like 4 units at dinner and they're admitted between lunch and dinner, you already know you're going to give them 4 units. If you know from the get-go from the hospital that you're going to be getting a diabetic patient that's insulin dependent, you need to have the hospital send those orders over before the patient comes so you can order that medicine stat from the pharmacy. I mean, unless you guys have house stock, we do not.
And most of you will, I think. A lot of people do have one doctor that takes care of everybody once they come to the nursing home.
Yeah, we just don't have that. Type 2 diabetes, it's a metabolic disorder also, but it's when they produce insulin, but the cells are resistant to using the insulin that's produced, or it's got a little bit of lack of insulin. But they're usually not insulin dependent, and it is usually adult onset, and a lot of that is, weight is a contributing factor to getting that. Diet. I mean, it's usually treated with an oral medication like glucophage.
And it's also due to being able to exercise and get the movement used to break down those fat cells. I bet you guys feel like nurses now. I feel like we're going really, really in depth on here. It was a slideshow that was given to me and I've just kind of tweaked it. But just remember, you don't have to know all these details, but
You need to know some of them.
You need to know how the body works. Because ultimately you're going to be responsible. You're the one that's going to be signing off on incident reports. You want to make sure everything is handled correctly. Pressure ulcers. I think everybody knows what a pressure ulcer is, or you've seen one in your lifetime. I don't know if you've seen one that goes deep. I don't know what you've seen, but you will have some of these ulcers that go down to the bone. It's gone through the tissue, the skin, the tissue, and then it goes down to the bone. And those are hard to heal. Those are really hard to heal in this age group because the body does not repair itself like it used to. Do you want to talk about anything else? What causes?
A lot of the pressure issues are caused from, being in one spot or, being immobile, because residents oftentimes, as they lose their muscle mass, are not able to shift themselves or move from side to side. So they depend on us to do it for them. If we're not moving them, it only takes 2 hours for skin to start breaking down. So, incontinence. Incontinence is a huge contributing factor. So not only if they're immobile, if they're incontinent on top of that, you are doubling their risk just right there on their coccyx, their sacrum. I don't really see a lot here on elbows and stuff. If our residents are bedbound, we still get them up and put them in a jerry chair. We have like memory foam jerry chairs that recline, so that way they're not just stuck in bed. We don't have any bedbound patients. We try to get them up, and we definitely move them. We have turning sheets that our nurses fill out and turn into the ADON at the end of every shift. So that way the aides and the nurses have signed off and residents are turned. I think that helps a lot, just knowing the moving. And nutrition is a huge factor. So if they're not getting enough protein, or if you notice a resident is starting to break down on their coccyx or their sacrum, that's one of the first things we do is we notify the dietitian. and the certified dietary manager, and I'm notified of any red spot, period. As soon as it's red, then we automatically start the creams, or we have, butt cream routinely, but then we'll put the trypsin or something if it's a stage 1. If it's more than a stage 1, we go ahead and draw labs, because we want to see what their albumin level is, what their protein level is, and we implement supplements based on what those labs show.
There's a definition of what a pressure ulcer is.
And they're usually over a bony prominence, but I have seen pressure ulcers that you think, I've seen one on the outside of the leg, and people thought it started there, but then once you get into it, it's tunneled all the way up to the hip bone. So that just might have been where it's open, but sometimes pressure ulcers are under the skin, they're tunneled, or they're in so many, it's so big that it's just the open area you see, but it's tunneled underneath the tissue.
And your nurses should be measuring these. They do an assessment, and every time they do a dressing change, they need to look and see what's changed. If the tunneling has started, they know how to do all that.
And here we don't have a wound care nurse that specifically that is her job. So we do have a physician that comes in anytime we get a wound. She is what is that? Plastic surgeon. Yeah, she will come in and assess the wound and give us the orders.
So don't feel bad about reaching out to somebody to look at these. Not everybody's going to have a wound care nurse. Like I said, we don't. I expect all nurses, as a nurse, to know what an ulcer is and to know what to look for and to know how to assess that. That's in their job description. So they can utilize that. Do you ever see any deep tissue injuries?
Yes, we usually see those. That's what I was talking about with the wheelchair foot pedals. They'll bang themselves on their shin or on the side of their leg, and then all of a sudden you've got this huge ulcer. Well, it's not really a pressure ulcer. It's a suspected deep tissue injury. They've injured the tissue, and usually we see these if they have vascular issues where they're not getting a lot of perfusion in the lower extremities. That turns into a wound, and so we don't do it as a pressure ulcer, or we don't stage it as a 1, 2, 3. We stage it as a deep tissue injury.
And what is it that causes heels to get boggy? They get soft on the heels. That'll happen a lot in a nursing home for people who lay in their bed all the time. Make sure you're propping those up. But what is that like?
Well, so when you touch them, it feels, because heels are soft anyway, but this is different. It feels like a very ripe avocado. So you're gonna touch it and it's mushy is what it is. So a lot of people, when they float the heels, I've noticed with my staff, they float it on the heel. Well, no, you have to float it where the heel's not touching, where you can move your hands and stuff under your heels. So heels are a big deal.
And that's basically due to them lying in bed and laying in one position, or in their recliner, putting their legs up. It's always pressure on those heels.
These are the different stages. There's 4 stages, 4 being the worst. It's usually deep and it reaches the bone. It's got the most extensive damage. But there is one that's called unstageable. And the reason that it's unstageable is because you can't actually clearly see the wound bed. It's either got white slough on it, or there's pus or something like that, where you cannot visualize. So you cannot stage it. It has to be an unstageable wound. One is just, it's non-blanchable. The skin is not broken. So then it goes from a 1 to a 2 to a 3, and then the 4 is the one that can include the bone.
And do you use the staging process on your assessment?
Yes.
Okay, is that when they come into the building?
Yes. So
Okay.
that is one reason, when you really want your nursing staff upon admission from the hospital to do a complete head to toe. You want them to look in between the toes, the heels, the elbows. You do not want to own any of those wounds.
And if they come to your facility and you don't claim it on that first assessment, you own it. It didn't happen at the hospital because you didn't catch it. A lot of these come from the hospital, but nursing homes get blamed for it because your assessment's not done properly when they first are admitted. You've got to check every little area. And again, also the CNAs, they see the skin the most, and they can report those. Make sure they're reporting them to their LP in charge nurse. Make sure that wave of communication is open. You want to make sure that communication across the nursing area, everybody's talking to everybody. Make sure this everybody knows if there's a wound we need to be careful for, or not get wet when we're showering them. You have to protect those wounds and get them well as soon as you can.
And our nurses do skin assessments weekly. They do a head to toe, including skin assessment, full vital signs. So they do that weekly. So the nurses are laying eyes on the skin too.
And the public, of course, over the last century, have nursing homes have been known for sores, bed sores and pressure sores, and nobody wants to see that in a judge's area up on a big screen, this wound. And that's exactly what the attorneys will do. They will take that screenshot that you have and blow it up so it's major on if you have a jury trial or whatever. You will be subpoenaed probably if anything ever goes to a lawsuit. Your nurses that had any documentation, and that's the first thing the attorneys will tell you is anything you have that they're suing you for, they will make it a ton bigger in the courtroom. So that's why a lot of people settle out, because it's really hard to win. And the public opinion of nursing home is bed sores. We haven't got over that yet, I don't think. But we don't see them a lot, do we?
No. We freak out a little bit as soon as someone's red.
Yeah, it's important to catch that wound that may be starting with a red spot, usually over a bony prominence. It will just deepen and deepen till it just one day it opens, and it's a sore that you're going to own because it is yours. So make sure your staff is turning and positioning frequently, getting them up. Don't let them sit in one position and sleep all day. The nervous system. Tell me about the nervous system, Jackie.
The nervous system is what sends all your neurons and your neurotransmitters. It's what produces the things in your brain. It produces like the dopamine, and it produces a lot of stuff to help you sleep too, the serotonin levels and stuff. It is what your brain is, your nervous system. It's what tells your body what to do, what tells your body how to move. And it also, the nervous system part of your brain is that it regulates your body temperature. So a lot of the stuff that goes on, all the stuff that pretty much goes on in your body is controlled by your brain.
Your nervous system pretty much goes in, causes impairments everywhere, doesn't it?
Yes. So like your hypothalamus is in your brain, and that regulates your temperature. So that is what causes a lot of sensitivity. You know, not only do you have thin skin when you're getting older, but if the parts of your brain aren't working correctly, then you're not gonna, they sometimes aren't able to tell if they're too hot or if they're too cold. A lot of the times they cannot process information the same. So like if you're talking to a resident, it may take them a minute for that message to get to their brain, for their brain to process it, and for them to respond to you. That's some of the things that go along with dementia. So we have tried to teach our staff that when you ask a resident a question, you need to give at least 90 seconds for them to process it, and then wait 90 more seconds for them to answer. So don't immediately go, Cheryl, what do you want for lunch? Okay, and walk away, because they haven't had time to process it.
They don't even understand the question at that point.
And that's a lot of times. Sometimes when staffing goes in to toilet people during rounds, they ask the resident, hey, do you need to go to the bathroom? Do you need anything? And the resident says no. They walk out of the room, and then 5 minutes later, the resident's on the floor. it's because we didn't give them time to process the information. And then after you mentioned going to the bathroom, you left, and they're like, oh, you know what? I do need to go to the bathroom. And then they get up to go to the bathroom and they fall. A lot of the sleep disorders that come along and just the brain shrinking and the neurological issues with that cause behavior issues. So the non-sleeping, we have a lot of residents that are up all night.
They may want breakfast in the middle of the night.
And we do that. We'll give them food whenever they want. But a lot of residents either sleep all day and are up all night, or just don't sleep at all. They may take little cat naps all 24 hours, like they never actually sleep, and they pace and they pace and they pace. And some of our residents with the neurological issues, that's where a lot of the neuropathy from diabetes comes from in their lower legs, and the little nerve endings are firing, and there's not a lot of that can be done to calm that pain. It's a terrible thing. So part of your nervous system is also your cognition on, like how you process information, how you're able to communicate, how you're able to conversate. So we do a mini mental, and we do a BIMS.
What's a BIMS?
A basic interview for mental status. So we do that with our MDSs and stuff, and the score is from 0 to 15. 15 being like you didn't miss anything and your all cognition is intact. You answered every question. You were able to recall the 3 items, stuff like that. Part of your cognition also that does with your nervous system is your depression. So you need to constantly be checking for depression. A lot of our residents we've noticed during this COVID have had increased depression, where they were never depressed before are now showing signs of depression. So make sure that your nurses are assessing for that.
Yes, and as an administrator, a lot of times that's the way I look at it when, let's say, whether a POA should be enacted or not, or I should be talking to that person or I should be talking to somebody else. I check their BIMS, make sure if the resident is capable of understanding whatever it is I need to talk to them about, any changes. It's always about, I always ask about that mental status because we have some changes to see if I need to persuade the family they need to go get guardianship. It's just real important as far as the aging process for you guys to have a handle on what their power of attorneys are, how they look, and who's in charge and who's first to notify. You got to get all that stuff right. Okay, let's see. Do you do it, or does the speech therapist do it on their hurry bow? Terry, on the speech therapy eval? Oh, the BIMS.
We do it.
The nurses, the MDS coordinator usually does it.
Or nurse does
Right.
it on admission.
So that way it's the same person a lot of times that's doing it, so we notice changes. And how often do we do a BIMS?
So our BIMS, we do it every 3 months. But if we notice like a change, like they started to be more confused or whatever, we will do a mini mental and another BIMS. But ours is usually pretty much every 3 months is the same people. Our residents we have 2 MDS coordinators, and they are both nurses. One's an RN, one's an LPN, and they make sure that they have the same residents. So it's the same person doing the BIMS, and they do it the same way. And that was actually a PIP that we did for one of our QAPI. We noticed that if a different person was asking the questions, the resident would answer it differently. So we made sure we tried to do the same person.
And Tracy, you said that you have the speech therapist and the MDS nurse do it. So you have the speech therapist do it even if they're not doing an eval? Is that what you're saying? You just automatically call a therapist in? Is that the way you read it?
No, we're just doing it on skilled.
You're just doing it on skilled. Okay. Okay. Yep. That's good. That's good. They work a lot on memory, speech therapists do.
And that would be something we can ask for us to do.
Yeah, that's a great idea because we hadn't thought about that.
Because we don't have therapy in-house. We have a contract therapy company, and so we don't have a speech therapist here all the time.
Yeah, she says we take the one
Yeah.
that will give more bang for the buck. There you go. Always thinking. You'll be a good administrator. And here's a really confusing math problem.
And that's kind of, you know, if you look at that, that's kind of what it is with residents. Like, they may see it different than you do, or, you know, perception and cognition are not always the same for everybody.
That's for sure. And not every resident will age the same or have the same cognition problems. That's why you got to treat them as individuals. Here's another one. I want you to read that paragraph in the middle and tell me how many F's you find.
This is a lot easier in person.
Yeah, I'm sorry. This class is a lot better in person. We're finding this difficult, but finished files are the result of years of scientific study combined with the experience of years. Does anybody want to tell me how many F's they see?
Five.
Nope.
4.
Nope, you're close. Make sure you're reading all the F's.
6.
Our brain is not trained to see the word of as an F.
So everybody that guessed, you're all close, but that's the majority. People do not read the F in of.
And so that just kind of goes to show you, like, cognition wise, for someone that has dementia, their process is different.
Yeah, you just don't process of, which is strange because every one of us will read that and not read those 2 F's, 3 F's. Think about it. There you go.
So the vision and the hearing systems, they can decrease, but not always. But when you can't see and you can't hear, then you're they sometimes put themselves in situations that they shouldn't be in. We've had residents that can't see, you know, walking where they could fall because they can't see. So their perception is different. So it can cause the falls and the accidents. A lot of people, we do have a resident, she's 102 and she is sharp as a tack, but she cannot see. So she does not come out to activities. She doesn't like the fact that she can't see to do bingo. So she has to rely on somebody else. So she self-isolates. So you find a lot of that with the hearing and the vision impaired. Because they can't perceive it the same way as everybody else and they need a little help, then they will self-isolate and they will not actually participate in the activities. So that's a sad thing with some of the dementia and some of the changes in the eyes and the ears. And a lot of times, like the medication, or say our environment over here has changed just a little bit because we've had an expansion. And so our residents, when we first expanded and opened our new area, it was a hot mess because it didn't look the same to them. It didn't sound the same to them. They couldn't, like, the ones with dementia could not cognitively understand that the walls were different or the pathway to get to the dining room was different. So it was a really hard adjustment for a lot of them. And like we knew it would, as nurses, we knew it would, and Cheryl knew it would, but we have a CEO that is non-medical, and he was so caught off guard by how much that it affected our residents. So, especially I think if you're non-medical, he was wondering staffing was doing or what was going on, because these residents were now agitated, or, they were so confused. And I was like, well, we changed their whole environment. It doesn't look the same. It doesn't sound the same. So they're not going to act the same.
It was a very good adjustment. Anytime you move them. And a lot of times just moving into a nursing home area, that's huge. They've come from their home that they lived in for probably 80 years, and probably not 80 years.
It's been hard with the COVID too, because we have an actual isolation area, and then an intake area, that's just for our admits for the quarantine. And so they get used to that room for 14 days, and then we have to move into another room. So we've noticed that has been really hard on a lot of our new admits.
Here's some of the changes that we see.
A lot of our residents with their taste, they either want really salty or they want sugar in everything. So most of ours tend to go to the sweet. We add a lot of brown sugar to oat milk because that's what they like. That's how they can taste it. When they take their medicine, if they have to have it crushed, a lot of ours we've noticed don't like the applesauce because it's not as sweet. So they like chocolate pudding. So we go through a lot of chocolate pudding. Saliva production, we've already talked about that. It decreases. So so if you're not having a lot of saliva and your taste buds, are diminished, it's just they don't want to eat. If you can't taste it and it doesn't taste good, that might be a lot of your weight loss. Is just the changes in their body. We don't have a lot of residents that have the tinnitus, the ringing of the ear.
That's miserable.
But we do know that they cannot hear the high frequency as much, so they don't have a problem hearing my voice a lot of the times. But some of our younger staff that have higher pitched voices, the resident will not be able to hear them, and I can repeat at the same volume and they can hear me. So it does, your ears change just a little bit.
And usually what, deep voices they hear better.
Mm-hmm. And the eyes change. Not everybody's eyes change, but we do see quite a bit of macular degeneration and cataracts. Night blindness, I wouldn't, necessarily.
We don't really know that so much because they're not out driving.
Sleep pretty well.
And I will say we had 3 people get the right answer that chimed in on that. How many F's? Julie Kastler, Terry Binsky, and Joel Avila. Hope I didn't butcher your names. Here's going to be a lot of the diagnosis that you see is dementia. There's all kinds of dementia.
And it's not a part of normal aging. I know everybody thinks that just because you get old that you're going to get forgetful and you're going to get dementia, and that's not true. Dementia, taking care of dementia people is one of my favorite, because you can have the same conversation with them 5 days or 5 times in a row in one day, and for them it's a new conversation every time. You can add a little bit. Most of ours are happy. They go through the phase where they're not, and they may be a little aggressive, but we try not to medicate as much if we don't need to because it increases their risk for falls. Our medical director is really big on trying to get the behaviors without having to medicate them. But there are different things that can cause dementia, like Parkinson's and Lewy bodies. And it's not, a lot of people think that dementia is just Alzheimer's. Well, sometimes medicine can cause medication-induced dementia. And sometimes if you get off that medicine, it can clear up a little bit. But dementia, the thing that's sad about the dementia is, their social and their intellectual it changes a little bit. We have residents that still, they revert to where they think they're in first grade, and you just have to go along with it.
Or they're back in the farmhouse with
Yeah.
their sisters and brothers and mom and dad.
And, on the doors where everyone exits, even if, because like ours are locked, but it says if you hold down for 15 seconds, door will release. I promise you, they may think they're in first grade, but they still know how to read, and they will read it out loud to you and just hold on to the door and try to go. So just because they have dementia does not mean they are not still intelligent.
For a lot of you discussed the differences of the dementia. Does everybody know what Lewy bodies is? It's a big part of dementia.
They hallucinate.
Susan Good says, play the piano and sing, sing, sing.
We do. We are a certified music and memory facility. We got that through Leading Age. And
Tell me about that program.
so music and memory, there is actually several videos on YouTube. If you look up, it's Henry is the one I like the most. It's a little African-American man who, you know, he's in himself and they put music on him, and then he's able to talk to his daughter after he's listened to some music. It is very moving. I love that video. I show it to my staff. And so with music and memory, they've noticed that if your residents listen to like the music they like, they're able to interact with you more after they take the music off, even for up to 10 minutes. So we do have iPods that we have for residents that want to listen to music. And when they move in, we ask their families, what kind of music do they listen to? What kind do they like? So that our activities director can program it into an iPod if it's not already in there. We have, our iPods are like a 50s band or Big Bang band, or, you know, they're all individualized so we can put music on whatever they like. So we play a lot of music, but music and memory is a huge thing with dementia patients.
Yes, and those are good tools for in-services with your staff. They need to know, see how these people can change by just some simple activity they can do with the resident. It increases it just makes it more enjoyable for the
So
resident.
we had a resident that had Parkinson's disease, and his wife was here every day with him. And towards the end, it was getting hard to get him to walk to the dining room. So she had heard about boxing and Parkinson's. Well, we don't offer that here. So one of the aides took it upon themselves to look up things to help this gentleman with his walking. So she found out that Parkinson's people can dance. If they have music, they can dance. So when they were trying to walk him to the dining room, they would put on music, and his wife would push the wheelchair behind him, and the aide would walk backwards and dance with him all the way to the dining room, and he made it every time.
That's a very good, YouTube that too, because there's a lot of moving experiences on YouTube for what you can do with these Parkinson's patients. I've seen them move down a lot, and sometimes they use the music in therapy and PT to get people with Parkinson's to move better. It's two different dementias, primary and secondary. Jackie?
For me, we treat kind of dementia the same as they get older. It doesn't matter really where it originates. It matters how you treat them. So it can be, you know, like I said, medication-induced, nutritional, like a secondary dementia, but it still presents as dementia. So you just need to make sure that you know, treat them with kindness. We do not reorient them at all, ever. We don't say, oh, remember it's 2020 and your mom passed away, or, you know, remember it's 2020 and your son passed away. We do not do that. We meet them where they're at. Our staff has been taught that if they think they're in kindergarten, then we're their friend in kindergarten. If they think they're at a spa, yes, it's the nicest spa you've ever been to. And we did actually have a family that wanted us to go through this book when their mom would forget, and it had obituaries and stuff like that in there. And she relived those deaths every single time. And until finally I had to be like, look, we're not going to leave that in her room anymore. It's cruel. We don't like it. It makes her cry. So you will have to definitely educate families on dementia.
And the family actually wanted staff to,
Yes.
every time she would say something that she wasn't in today, as the date of today, with her mind, he would want the staff to do an intervention and go through that book with her. Well, it was so detrimental for her. So always meet them where they're at. What we find is a lot of the ladies, they will like baby dolls. They feel like it's a real baby, and they will carry it around like that. And it's just so helpful for them to get through the day. And a lot of the men, they want to do chores, or they used to hard work. So find something for them to do. And we have a lot of luck with the animals. You can do therapy dogs, but also they make these cats and dogs that are like real life, and they'll purr and do different things like that.
Doggy bed.
Yeah, they're interactive, and I'd say we've had a great success with
Yeah,
that.
and our baby dolls, we buy the real life looking baby dolls that aren't little, like they're the size of a baby. But we do a lot of validation therapy here. If that's what that's called when you don't reorient them, it's validation therapy. And you can look that up on YouTube too.
And you can watch some Teepa Snow,
Naomi Fells.
she was with the music.
Mhm.
And it's just, if you need those names, let us know, because you can YouTube them. And there's some great teaching experiences on there. And a lot of things that you could cover in an in-service whenever we get to do in-services and stuff in a group again. It just reminds them of home. It gives them a comfort to know that they have an animal or a baby. That's just where they are in their mental status. They cannot come to today. They just can't. And that's okay. What we need to know is that's okay. And you need to make sure the families know that's okay. And I know this is not your mother. I know this is not the mother that raised you. She's at a different stage. Try to do as much teaching as you can to get the family aware that this is just where their mom and dad's going to be at right now, mental status. And just talk to them in that world. Still communication, still makes them feel wanted, proud, loved. Alzheimer's is very much a progressive disease. It causes a lot of cognitive impairment, which in part makes the memory loss and the confusion. They aren't able to reason any longer. They aren't able to make decisions. A lot of times if you take a menu to them, they can't decide. The words are jumbled sometimes. We usually ask the resident, tell them what's on the menu and let them choose. But a lot of times, are they unable to choose?
They're unable to choose, but this is where we have talked to the families on admit and we ask them kind of what their mom used to eat. And sometimes that changes. Sometimes you have residents that used to love like fried chicken and no longer eat it and will only eat finger foods. So we make sure we have finger foods available. Like we try to change constantly as they're progressing through their disease, because you know, as they progress, they do change, their taste buds change, like everything changes.
And they may be pacers. They may like to walk constantly. They may not sit down for dinner. And we've had that happen here. We had a little lady that she had to walk all the time and she wasn't going to sit at the table. So we just got some finger foods, made her little sandwiches or anything that she could hold and take with her while she was walking. So you have to customize their plan of care to fit them. Make sure your care plans are not cookie cutter. Make sure there's different interventions for each different person. And one thing Jackie mentioned was on admission, they get the residents' likes and dislikes, and we carry that through so that when they no longer can remember what was good to them, we know it and we can produce those foods for them, or we can make that memory happen. So it's important to treat each person as an individual. They all have different lifestyles growing up. Everybody's not the same. Don't treat them the same.
And with dementia, I mean, with Alzheimer's, there is memory loss and stuff, but I have found that with staffing, because most of my staff stay a long time, if I make sure that I assign them in the same place, the resident does get more comfortable. And it may just be that person's energy. They may not remember who that is, but I know that, we're lucky enough here, we're in a CCRC, so we get to know these residents when they're in independent living. I had a resident that I had for 10 years here, almost 11, and he may not remember everybody else, but he always remembered me. And so when the staff could not get him to do stuff, I could go on the floor and just say, hey, and he would do it. And the same with his wife. When she later came in, as soon as I walked on the floor, she automatically would come to me, arms out, arms open. And it may not be that she remembered my name, but she remembered we had a connection. And so I find that with a lot of my staff, the Alzheimer's patients or dementia patients prefer certain staff. And I think that's just also the way you treat them. Like, you have to be patient, you have to be slow, you have to give them time. It can't be like, okay, get up, we're going. I mean, there has to be a different way that you approach them. So you need to make sure you find the right staff to care for the patients with dementia, no matter what the type of dementia it is.
And Alzheimer's, like Jackie said, is part of dementia. It's a whole disease process on its own. It's different than some of the other dementias.
And actually, Alzheimer's cannot be diagnosed until you do an autopsy because it affects the white matter in the brain.
Yeah, that's something we learned early on.
Personality changes are huge with Alzheimer's, though. You have some people that were the sweetest person on the face of this earth, and their family comes to visit them, and they're like, I did not know my loved one even knew those cuss words. Or, I didn't know that she was violent at all, and she's threatening to stab me. I mean, it happens, and it's very sad for the family, because after the family leaves, the resident doesn't even remember it happened. So Alzheimer's disease, or any kind of dementia really, is really hard on the families. I mean, it is hard on the residents, but the residents don't remember that they don't remember.
But
So
the families do.
The families, it's very hard. So anybody that has dementia, just remember, you're going to be in close contact with those families, because they're going to need help getting through this.
And we do a lot of discussion with families. It really hurts them. Like, they may see their mom every day, and that resident says, soon as she sees her, she will say, I haven't seen you in like years. What are you doing here? And a lot of time, like Jackie said, they don't even know who their daughter or son is. And that, it takes a lot of counseling on the administrator's part and the DON to get these kids, these children, up to where they know how to speak and how to let some of that go, so it's not constantly breaking their heart to see mom like that. And a lot of times they don't ever get there. A lot of times it's just so hard for them. They'll still come, but it's hard for them to see their mom like that. Wouldn't you say?
Yeah. And eventually with Alzheimer's, they lose the ability to even feed themselves or, perform any of the ADLs. And so that's where they'll become completely dependent on staff to be fed, to be changed, to be moved. This is just one of the, it's not labor, it's not like intensive where you're going to take a lot of meds and stuff, but it is the most heart-wrenching, I think, disease there is, because you just have to love what you do in long-term care to be able to take care of dementia patients. Because you have to know that they would not hit you, or they would not be mean to you if they had a choice. Most of them.
Becky, how do you handle staff that they get upset when a resident hits them, and it's not really the residents, they're acting out, something's bothering them, or they're mean to an employee? Some of them can't handle it.
Right. So then for those employees that feel like the resident, I've had employees tell me the resident doesn't have a right to talk to them that way. You pull them in and you try to counsel them the best you can, and eventually you have to tell them this may not be the job for you, and that's okay. You don't want someone in your facility that has a short temper and cannot deal with that they can't, process that the resident is not doing that on purpose. If your employee's never going to understand that, then you are risking your residents. And as a DON and as a nurse and as a human being, I would never put someone in with my residents that I didn't think would treat them with compassion and kindness at all times.
And with the age group that we're seeing now, it's not often, but sometimes you'll see residents who don't want a certain person in taking care of them, whether it's a perceived something they did, or the way they look, the color of their skin. It's a hard pill to swallow as an employee, but you may have to make arrangements to work around that so that your resident's comfortable and will do their task. We'll continue showering for somebody, because a lot of times they'll just say, nope, I'm not going to do it. So that's a tough one for the aides, because like I said, it's a very thankless job for them.
It's a hard job.
It's I've heard it's the most labor intensive job there is. And as you know, nursing homes have the highest regulations. I mean, we are tougher. It's tougher to operate a nursing home than it is a nuclear plant. We have more regulations than a nuclear plant. This is all about the dopamine and how we're going to talk about the Parkinson's again, how it affects the neurons in our bodies and the nervous system.
The dopamine is not, so in a normal, your neurons can move and your receptors can accept it. In a Parkinson's, they can't. It's the dopamine that's not produced as much and it's not used the right way. And Parkinson's is really sad. It is so sad too. It does lead to complete disability in the cases that I've seen. And for me, when Parkinson's first starts out, it's very sad because the residents, they have the tremors, and not all of them have bad tremors, but some of them do. When they're trying to get comfortable, it's hard for them to be still. I've seen the muscle stiffness, the posture when they walk, like their feet shuffle a lot. And so when Parkinson's first starts, it's very sad because their mind is still there. So it's really sad because they get mad and they get angry. But also as it goes on, their speech is like low and it's kind of like, and they know what they're saying in their head, but you can't understand it. And so that can make them mad. And then as it goes on, then they forget, and then they can't talk, and then they get really rigid and unable to move a lot at all. It's very sad. And that's where we found that the music in this one particular patient that we had helped him move. And that's why I think they're associating a lot of movement like the boxing with Parkinson's, because it helps alleviate some of those symptoms. I don't know how, but it does.
And as nurses, a lot of times you can see somebody in independent living or in public even, that you look at them and you know they've got the start of Parkinson's. Yes, the shuffling is the
They
major
kind of
one.
lean forward when they're walking. It's like
Their posture.
it's kind of like when you have little kids, like they're cephalic heavy, like they're heavy on their head, so they're always running with their head first, and that's kind of what it looks like when someone has Parkinson's.
Like they're walking downhill.
Yeah, it's very, very sad too.
And you will see a lot of the garbled speech also, and a lot of times it affects the way it gets to the brain. They can be slower in their communication. It's just, it affects every part of the body. It does. We're going to take a break. You're going to take your lunch break here. It'll be a short afternoon. I can tell you that already. I don't know how to stretch this out any longer, and I know you don't want us to. It's a lot of information in your brain. Come back with some questions for us, because we're used to interacting with the staff and with this group, and it's kind of hard to do when we're on two different sides of town. This is just so impersonal, and I am such a personal person. So it's hard for me not being able to see your faces and see if you're getting any of this, if it's way too deep. I hope you walk away with something today. When we get back, we're going to talk about emotional well-being and mental well-being. And then we're going to get into different, your administrator role, your DON's role, your infection preventionist role. And we'll get into that a little more when we get back. Let's see, it is 11:40. I guess we'll meet back here about 12:40. Does that sound okay with everybody?
This conference will now be recorded.
Okay, guys, I hope you had a good lunch. It's hard to get back to work after having lunch. But we're going to talk about mental health, emotional and mental well-being. There's a lot of emotional and mental stuff going on in a nursing home. There just is. We're going to we talk about depression, and depression can be a mood disorder, and we actually see it a lot more in the women, just like statistics show. That's one of the biggest fights you'll have as an administrator with nursing homes, is fighting that depression in your residents. They're moving away from home, or it's a complete different environment for them, or they're not used to having somebody come in and help them with everything. You got to watch for that, and don't ever hesitate to seek help from a physician and have them look, or maybe send them for a eval of some sort. I don't always like to do that, because some of those places, we just don't have a great resource for mental health. There's not a lot of, and for depression, there's not a lot of treatment out there, or good treatment. Let's say if we ever have to send anybody out to a psych hospital or for an eval, a psych eval, it's very, very hard on the resident. Jackie, do you think has it been successful for a lot of our residents for send them out for a psych eval? No, you don't have anybody?
I mean, there's been maybe one, but usually they just take them off all their medicine and start back from the beginning.
And that's exactly what they do. First thing they do is take all their medication away, and then they'll start adding them back one at a time to see how the resident handles it. Sometimes they'll put them on some kind of mood enhancer or some kind of antidepressant, or they can do like Seroquel. We see a lot of Seroquel, and Depakote is another one that they'll use. And you have to use that caution with those, because they have awful side effects. They can have. And so we always try to distract, reorient them, not reorient them, but give them an alternative, something to do. But you'll see this depression and anxiety. It demonstrates in the elderly a lot. They're used to having that depression. They don't want to take usually anything that's going to change their mood or an antidepressant, because they were raised in an era where you didn't do it. You didn't treat depression. You didn't say you were depressed. You didn't act depressed. You just went about your business. These are people that lived through a lot. They've been through, a lot of them have been through the Great Depression. They've saved a lot of money, and now they're having to use it. But they have lived through all that. And back then, you didn't talk about your feelings. You kept everything to yourself. They didn't share it with their spouses. They didn't share it with anybody, because it was taboo back then to have depression and to be treated for it. So we see it a lot more in the younger generation, that they seek out treatment. They will treat their depression. But in the nursing home, we have to fight loneliness, and they get bored. And I'm sorry, my mask is not saying that, Jackie. I'm trying. I don't want to contaminate Jackie. But you, as an administrator, what you'll learn is that depression, that loneliness, that boredom, that's what hits a lot of your residents. And in this COVID, during the COVID pandemic, we've had a lot of that. You've had a lot of that with people, because maybe they were used to seeing their family every day. Maybe they're used to talking to their family every day, and all that slowed down for a little bit till we could get our hand on this COVID, get a handle on it, and figure out alternative ways for them to still be with their family, still have that attention, still have family involvement, and then their body breaks down on them. So your hearing loss, your vision loss, that is major. Vision loss is major for these groups. Many of them like to read. They can no longer read. You can get them the books that are on tape. We use those a lot, and you guys will too. But for a lot of people, relaxation was reading for them. And we maybe have a couple with a reading machine. But sometimes that's just hard for them to physically work and be able to move to take care of some of that stuff. So just remember loneliness, and that will lead to depression. It's such a big risk for that. And right now, we're dealing with it because of the COVID.
And sometimes when we can do admits, we do have to medicate for situational depression, because they come and then they're just so depressed that they've had to leave their environment that, nothing we do to help them is working. So we do temporarily medicate for situational depression.
And here's talking about there's also some side effects that affect it. There's all the medications, if they're a polypharmacy, they could all be interacting together and causing lots of side effects. So watch out for that and be careful to treat and make sure it's a good level for them, what you're doing, and that it's not something they're opposed to. But it often goes untreated, and of course that's because they don't want to be depressed. They don't want to take another medicine. They're fine, but you notice the change in them. So be sure and talk to your power of attorneys and do your care plans. Make sure everybody's on the same page. Find activities that we can try to get them involved in. Maybe they don't like the activities you're having, like an ice cream truck come by. I think everybody likes the ice cream. We have an ice cream cart that goes through once a week. And we'll go down hall to hall and let the resident pick up old time type ice cream bar or popsicle or whatever it is that they like. We try to make happen and make it special by having it once a week and calling attention to that area.
Make sure your social worker is involved. If someone triggers on the MDS or at any time for depression, make sure you let your social worker know, and she can go and talk to them.
Now, social worker is a big part of your team also. They have their parts, and everybody contributes to make a whole team. So a social worker comes in when they're admitted, right? Gets involved.
We have a social worker. She's part-time. She works 20 hours a week, but she comes in within 72 hours of admit, and she talks to them and does, her interviews and her ID notes, and sees where she needs to follow up on stuff, especially for skilled patients, on stuff she needs to follow up before we discharge, and kind of like what the home environment was like, so we can help get them acclimated once they're in here. And if they're long-term care, she is here often enough during the week that she tries to see them pretty often when they first admitted, so she can help, with counseling or anything that's needed.
She also helps a lot with discharge planning.
And she does the trauma-informed care during her initial interview, because that is actually a regulation. So she has been trained to ask those questions, so we can, if we find anybody that, has been exposed to trauma in their lives, we can make sure their care plan reflects ways to take care of them or what may trigger that trauma.
And previously, we weren't required to do a trauma assessment. So when did that come out?
I think that was phase 3, November
Of 16?
last year.
Okay. So you can see these changes come about. We're always revolving in long-term care to try to do the best thing for the resident. As an administrator, you are responsible for these F tags at the end. And when you get surveyed, and just think about it as a daily thing. You want everybody to have quality care in your facility. I don't think any of you would want to have a facility where you don't have it stamped of your approval and know what's going on. So quality of care is something that you're going to know. You're going to hear from families, you're going to hear from residents, you're going to hear from surveyors. So it's something that your nursing team really has to focus on, as well as housekeeping and dietary. We all want the best care, and that's what they deserve. So they will receive that.
The quality care focuses on head to toe, in to out. I mean, mental, physical, spiritual. Like you have to make sure you're taking care of all that. And with the F tags, the administrator really needs to be familiar with the watermelon book. That's what they call it. It's the red book for long-term care surveyors. It has all your F tags in it. The newest book with the phase 3 additions has yet to come out, even though it's been almost a year since the phase 3 went into place. So the latest one they have is still from phase 2, but it'll have all your stuff in there and what the surveyor is looking for. You can find your F tags, so you can kind of do your teaching around what you know the surveyor is going to be looking for.
Oops. Okay, you also have to focus on wellness. Overall health will make a big difference in their life. So we offer exercise classes when we can. We can offer some now in small groups. You still have to follow your social distancing and mask. The fun part is trying to get your residents to remember to wear their mask. You'll have some that know they're supposed to wear it, but they always never have it on. And when you stop and say, hey, where's your mask? Oh, I had it on, but it's not in their chair, it's not anywhere around them. So they know how to manipulate things too. So you have to watch those. And what else? Exercise helps everything.
It helps lungs expand, so that helps oxygenate your brain, your body. And it can help ease some of the things from arthritis. Like if you sit and you're going to get stiff from your arthritis and you're going to hurt. So if you encourage your residents to move, even if it's just through restorative assistive range of motion, if you move their joints, I think their body will ache less.
And pretty much since we're a life care community, we've adopted the culture of wellness and healthy living. And that starts when they move in, when they're 62 years or older. So we just developed all along that wellness is an important part of their living. And we want to focus on that, not all of our disease processes. So any kind of wellness and healthy activities you can do will lead to them having a better life. They'll be happier, less likely to stay in their rooms, possibly, and it lets them set some goals and try to attain some of those goals. So we try to put that into practice in all areas that we do. We have new steps. They're the sit-down recumbent bikes that have the arms too. And you can, they don't have to be ambulatory to ride that. That's something that we can, as an aide or LPN or RN, we can walk them over to we can push them in a wheelchair, as long as they can stand and transfer and pivot, and they have some lower body movement. They can get on there and it helps strengthen their bones and build some muscle mass, hopefully, to make it better for them, for their lives. It prevents healthcare associated infections as well. Ignore that. I hope everybody's familiar with the infection prevention. Is somebody on? Infection prevention. That was part of the last change in Medicare too. It came out in 3 phases.
Yeah, and the IP was supposed to be in place November 28th of 2019 with the 3rd phase of the mega rule.
Yeah, you had to work on it we had like 3 years coming up to where you had to have it in a functioning position. And I believe it is required you have to be a nurse.
It used to at first was not required that you had to be a healthcare professional, but now it is.
So it has to be a healthcare professional. It has to, I'll tell you, this is a hard job right now. Not only do they take care of your infection control and all your quality reporting and quality improvement, now they have to take over all this COVID, the response that you have to it, the protection you put in place for your residents, the protection you put in place for your employees. They follow all this. If you're working in a facility now, this person is extremely busy. But she's also one of the most important parts to your team during a pandemic. She keeps the employees educated. She keeps all of us on our toes if she catches us without our mask, or let's say safety glasses if you're in an isolated area. And they're actually the ones responsible for the infection control surveys that we've had since COVID. Yeah, we've had 3 of them since COVID started. So be familiar with state walking in your building. It's just going to happen. We aren't always shocked when they come in. We expect them. You should expect them also. During the pandemic, they've been around a lot. They've been very helpful, but they have popped in 3 times, Jackie said, and each time our infection preventionist and Jackie, we pass with flying colors. They just want to make sure you're doing the right things, that you're following your own policies, you're following the regs. And remember that those policies that you make for your company have to follow the regs, but they may be stricter than what the regs are. So make sure you're following your policy. That will get you in trouble faster than anything. If you're following the reg, but your policy takes it even further, and you're not following those steps. And let's say like CPR. Not everybody's required to be trained in CPR, but you have to be certified. Vice versa. You have to be trained but not certified. And but our policy says they will be. So that will get you in a bind if you come up and you're not doing that. There's a lot of things that you can make your policy a little bit stricter and make sure you're familiar with your policies. Because the policies are usually a little bit different. They always have the guidelines to how you're supposed to, the procedure to how you're supposed to accomplish it. So make sure you're familiar with your company's policy. And I don't know how many of you are currently in training, or how many of you are waiting to get in to be a trainer in practice at your nursing home as the administrator. We had one here. She came right before the pandemic hit. And bless her heart, she was in school, the school that you're in now, but she got a major lesson while she was here. It was a great time for her to be here, because as an administrator, you've got to take this pandemic and you've got to make it work. But it's not just working for your employees, it works for your residents, it works for your residents' families, and it works for staff. So you've got to be really diligent about it. And like I told her when she was here training, this is the best time for her to sit back and just watch what goes on and watch the administrator, make sure, see how she handles or he handles all the stuff being thrown at us during this time. That's the first, I've been here 20 years, but that's really the first pandemic or any major thing that I've been through. And it was a learning experience. It was a learning experience for all of us. Because it just like one day you get up and bam, the world's changed. Nothing leading up to it. Believe me, I guess the warning signs were there, but everybody didn't react as quick. what kind of caught us all off guard out here. We never dreamed we would not have visitation. We never dreamed we would shut our doors. We never dreamed we would shut our gates. But it happened, and we had to find ways to cope about it. We would come up on a Saturday and try to plan how we were going to start this thing, how we were going to protect our residents to our best ability. And that has been our major goal the whole time. We fail, we try things, we fall down, and you have to just go back to the drawing board and figure out how to do it better. But it did take a lot of planning, and the infection preventionist, as I said, was up there getting everything going, helping us get all the policies together. It required, I don't know how many new policies.
A lot, and she is still the one that's reporting to the 5 different agencies every week on the COVID testing. Your infection preventionist must also be a member of your QAPI or QA. So they have to sit in on all those meetings. So, and she also is the one that has to come and monitor staff all 3 shifts at random times, and she has to keep track of that. She has to keep track and report anything that she finds that staff aren't doing. So right now, the infection preventionist is a hot commodity, and ours, of course, is certified. They were all supposed to be certified by November 28th of 2019, but as we have found out through this, there is a lot of places that do not have IP people, and they do not recommend that your DON be the IP person because it's a full-time job. So we're fortunate enough here that we just had our QA nurse absorb the IP.
And she's busy.
And she's great.
And she keeps us all in line.
Mhm.
From Jackie to me to the CEO. She doesn't hesitate to tell me when we're doing something wrong.
Yeah.
And she will correct you on the spot. So
Don't take it personal.
Yeah.
If there's someone in a position that you put in that position to learn that stuff, well, they're the ones learning it. They're the ones that know the rules. So if we're doing something wrong, we do not take it personal when she corrects us, even if we don't agree with it. I mean, she's following the rules that we put her in place to follow. So make sure that you are able to separate the personal and the professional, because she just means it in a professional capacity.
yeah, and if I ever have any questions, and then you do as the administrator, if they're doing something that you don't understand or you don't agree with, meet with that preventionist and have a sit down and let her tell you why you may be wrong. Listen, open your ears and listen, because, you know, we don't always have the answers and we need people to help us. So I could research and research all day and still not ever get the wealth of, I don't have room in my brain for all that information. So you have to have people around you that have that information for you, and trust that you put them in the right position, and trust that not everybody fits in the same category. So make sure, something we like to say here is, make sure you got the right person in the right seat on the bus. Not everybody can be a director. Not everybody has that kind of willpower to go forward and be a leader. But boy, they are so smart and they excel. Maybe they need to do something else. They're not in the right seat on the bus. So every one of you are driving a bus when you take your position, and make sure that it's a good fit for everybody. That way your bus will just roll down the highway. Now we're going to get into more about your job that you're going to have. There's a regulation. It says that you must be administered, a facility must be administered in a manner that enables it to use resources effectively and efficiently to attain mental and psychosocial well-being for each resident. So you've got to make sure with every guideline you put out there that it's not going to affect the resident. That if it does, it's going to make their well-being, psychosocial or physical, mental status be better. And that during the pandemic, Jackie, that was hard because you feel like you're taking everything away. That's the way I felt. And that hurts my heart because I don't like to see the residents upset. I don't like their family member to be upset. And more important than that, I don't like the staff to be upset. It was a massive change, and that's hard to get used to. And be aware of compassionate care. That's what I want to point you to. When you're the administrator, you can have some visitation for compassionate care. I don't know if we're ever going to open up again. It feels like it's a never-ending process. I don't know if we're ever going to get a control on the COVID in Oklahoma. It seems to be growing and growing, and I would like to see all the nursing homes decrease in casualties related to this illness. And we can do that if you have a great team and you work together. And then you pray every night that nobody gets the COVID. That's what I do. And the testing and stuff that you have to do, it depends on, like we talked about earlier, the different stages, the red and the yellow and the green, how often you have to do all this stuff. And as the administrator, the one thing you need to be aware of is going to be the cost. We have gotten a lot of federal money, the nursing homes have. But believe me, it doesn't cover the cost. You've got all kinds of costs coming out right now because number one, it's hard to get staff. You're having to advertise more for staff. Your staff will start and go through the hiring process. That's thousands of dollars when you go through the hiring process and then don't show up for work. And then buying the test strips, getting the lab out here to do it. And for the employees, you cover all that cost. And right now we're in the testing zone in our county where we do it once a week. So every week we burn through how many? And then if we get a positive out of those tests, then we immediately have to turn around and test every resident. So the cost is a big part of what you guys have to manage as the administrator. Is you have a budget and you have to stick to it. And in times like this, what are you going to do? You have to figure out ways to balance everything. Like, can you steal from Peter to pay for Paul? You know, it's just one of those things. You have a big job coming your way. And it's something you guys have accepted. And it's something very easily managed, but you're going to have your hiccups. Remember that. You're going to have your hiccups. Grow from those, learn, and, you know, just know that you're not always right. We think we do, know everything that's correct, but we don't. And make sure the people under you know that they're supported by you. Every day will be different. But your role is going to be, you've got to have the acceptable level of quality of care. Your employees need quality of care. Your residents need quality of care. Every department has to have that quality of care so that we can ensure that the residents have that quality of care. So, like I've told you already several times today, empower your department heads and staff. Have a relationship with them where they can come and have a conversation with you and know that it's a safe zone. That's one thing for sure. I always make sure when somebody's coming in to talk to me, whether it's to report something or do they just need a place to vent. We'll shut the door, we'll talk it out. It may be something they're very upset with or something I did and they're upset with me. I want to know. You can't improve and move forward if you don't know what the problems are. So always give everybody a safe zone. If they, I always tell the floor on the staff on the floor, you know, if you've had enough, take a break. Go to your charge nurse, take a break, and go somewhere where you can just scream or whatever you need to do. But everybody needs that safe zone. Is that how you handle it, the nursing? And sometimes they just need to vent to feel better. But a big part of your job is communication. Of course, you got the coordination of all departments, but you've also got to communicate with everybody. You got to communicate with the public and the inspectors. The inspectors, pretty much, they've been focusing on nursing lately, so they just spent the majority of their time visiting with the infection preventionist. But on a normal survey, they will meet. I usually go meet them at the door. Jackie will too. If it's AL, my other department head, or whatever it is, but they will go through every department in your building. And they will even ask you questions about how to regulate a thermometer, how to test the thermometer to make sure it's working. That caught us off guard one time. So make sure you know that stuff. It's the little things in nursing. What do you see, Jackie?
The ombudsman that comes, she'll either talk to me, but a lot of times she wants to talk to Cheryl. So make sure as the administrator, you know your ombudsman assigned to your building. Ours, her name is Patricia, and we both know her well. She calls Cheryl, she calls me. And as the administrator for Cheryl, in between departments, I do not know why, but like between nursing and dietary, there always seems to be a tiff here and there, whether it be the staff on the floor or even department heads. And so as an administrator, it's nice to have someone that will be like, okay, so you guys need to tell me what happened and then we need to figure it out. I mean, don't put yourself in the position to take one department head's side over another. So try to be impartial if you have issues between department heads. That's key for me. I never want to feel like my department doesn't matter, and I know that our dietary person, Eric, doesn't want to feel like his department doesn't matter. So as administrator, make sure all your departments know that they matter equally. I mean, because we can't run without dietary, and they can't.
They said another one. I didn't even. But she was laying down, and then she got up, and the song was very inappropriate, and her dancing wasn't very appropriate. It was just like, this isn't.
Somebody's not muted.
But that one where there was a bunch of her dancing for the
That was
funny. Because at one where she's doing all the moves, but she is so not into it.
No, she just
I
like.
can tell
Yeah,
who's
like, oh, whatever.
not muted.
It's nothing to her.
Somebody's not muted.
That was the way she turned around and told Alex to come on or whatever she was doing.
Okay, we'll try to get through this. Like Jackie said, the ombudsman, you need a relationship with your inspectors too. You're supposed to have the same group of inspectors year after year. We pretty much get different inspectors every year.
They just reassigned them though. They went from 16 teams to 11 teams, and because they're having staffing issues as well. So they just went from 16 teams to 11 teams, and now those 11 teams, where it used to be certain teams only did long-term care and certain teams did AL, now our team will do all of the AL and all the long-term care in our area. So we've met a couple of our new surveyors recently, and they said that they will be the ones to come out and do our annual as well.
Yeah, that was right after they just moved those groups around. So, but you don't want to be a stranger to your inspectors, your ombudsman. Your MDS coordinators and everybody need to have a relationship with hospitals and discharge planners. If you have a marketing person for that, they also need to be familiar and make sure they're your marketing person and your marketing department is selling what you have. Sometimes make sure you guys work together, because you don't want them to oversell the care that you can give. Maybe it's something you can't give that person, and the marketing person doesn't know that. So make sure you're communicating there. But I can tell you the inspectors at the health department know who we are. And you want them to know who you are in a good way. And that's by being the professional person that you are and communicating with them. Don't worry about if you need to ask them a question. You can pick up the phone or you can email. We found that email's the best to get a response. But they want to work together with us. But of course, sometimes it's still intimidating when they walk through your door. It's kind of like you know they're coming, but it's like, oh, I didn't know it was today.
And if you're an administrator that's not normally on the floor, please don't go to the floor during surveys. That makes your staff nervous.
Yeah.
Because if an administrator that's not normally on the floor walks on the floor and the staff's already nervous because state's there, they're going to be looking at you. And the surveyors hear your staff talk too, because they're going to be like, oh, it must be nice for them to come out. They never come out. So it's okay for you not to be on the floor if that's not normally your role. But if you are not going to be on the floor on a daily basis, don't go during stressful times. That just makes it worse for your staff.
Yeah, and I don't follow them around. I don't try to make sure my presence is known. I introduce them when they first hear. I give them my card. I tell them to call me if they need anything, show them where my office is, and they'll come and get me sometimes, or they'll just pop their head in and ask a question. So make yourself available for them, but don't be following them around. That will make it worse.
And they will come if you keep candy in your office. A lot of people, that's when they see Cheryl the most. She keeps a lot of good candy in her office, so staff feels like they can pop in and talk to her. And that helps create that open door thing, because Cheryl can be like, how's everything going? And if something's wrong, they tend to blab while they're eating the chocolate in her office.
Yeah, I always keep chocolate because that's the best. Everybody needs a little chocolate in their life. Here's more of your role that you're going to have to do. Mainly you are non-clinical, but a big part of your goal, and as the administrator in a nursing home, to be centered around clinical. You'll see your deficiencies in dietary, you'll see your deficiencies in maintenance, or maybe there was a little hole in a firewall. You've got a lot you've got to know. And but a lot of it comes down to your nursing department, and that's why you need to be a good leadership role and work closely with them, and understand the delivery of care. Understand the stuff that we went over today. You're not responsible for that knowledge, but you kind of need the general idea of how a body works, how the nurses are treating them from head to toe, how it's not just they're sitting down there charting all day. Believe me, they're busy. They are so busy on the floor. Occasionally, we will walk through and see people holding up the desk or holding up the wall. And, maybe it's just a break. You just kind of watch that. You don't need to jump on anybody in front of anybody. That might just be a question that you would ask in private later of your charge nurse to make sure your CNAs are busy. Make sure they're not standing around most of the shift. I think you'll find that they're not. I think you'll find that they are busy. They are doing their job, and they get tired. So make sure they're getting their breaks too. So you will just assist with your healthcare professionals. You don't want to overstep your boundaries because you're not a nurse, or you may be a nurse, but that's not your role. Your role is to be the administrator, to supervise that area. So it's not your job to tell the clinical staff what to do. That's the main thing I want to say. I mean, as a nurse, That's not a problem for me. I'm fine with her taking over. I'm fine with all of our department heads taking their jobs and going off and leading their departments. You know why? It's because that's what they do. That's what they do. That's what they're trained to do. So
If you micromanage them, you're going to cause an extensive rub between you and them. If Cheryl were to overstep me and get onto my staff before I had the chance, that would not make me happy, and we would not have a good working relationship, because as the role of the DON, it's my job duty to supervise the staff that work under me. So you don't want to be the administrator that jumps in over your DON, or you're not going to be able to keep a DON.
no. And if I see something on the floor, maybe it's something I think that was wrong, I'll go to Jackie. And maybe I'm wrong. Maybe that's just not the way it is. And she needs to be able to tell me that. And she needs to tell me I'm wrong. Sometimes I get to tell her she's wrong. So you just work together. You don't want to be the micromanager, as we talked about. You want to be the coach. I don't so much use that any longer to describe it. I think it's still floating around out there. But we all have our vision. We all know what our mission statement is for your facility. And you know what you value. And hopefully that's the organization, including staff, including supervisors, including your residents. You have to value everybody. They are worth valuing. You lead by walking around, and I'd say Jackie does that a lot. All our department heads go on the floor a lot. I go in every department a lot. Who we are, who employees, if we get new residents, new employees, I try to always go and introduce myself. I want them to be part of the family. I keep current with Jackie, and I have assisted living also, so I keep a track of that for all incident reports, all admissions, all deaths, everything like that, because I want to know I want them to tell me before I walk in the next day and somebody greets me at the door and says, did you know so-and-so broke their hip last night, or we lost this resident last night. I want to know that when it happens. I don't want to be caught off guard by a family member at the door, anything like that. It's happened once, and I never want that to happen again, because that was embarrassing. That here his wife had fallen and broken her hip, and I was unaware of that. And maybe you guys are different and don't want to know all that stuff. You set your guidelines, you set what information you need to know, but just know those families will call you. So you need to have the knowledge of what's going on in your facility.
We have a HIPAA compliant app called Click. So anytime we have an incident, or we send somebody out, or change condition, or anything like that, all our department heads know. So that way we know if someone's going to be out for a meal or something like that. And we send it at all hours of the night, so all of us are up to date at all times. Cheryl also sits in on our CASPER meetings. We do those monthly, so we can go over our quality measures and our star ratings and all that stuff. Cheryl sits in on those. She sits in on our care plans. A lot of administrators don't, and I don't know if it's just because Cheryl's a nurse, but she sits in on every care plan. We have those on Wednesdays, and she contributes, and I think it makes the families and the residents feel better, or feel like if they have an issue, it's not stopping at me, that everybody from the top down knows, and that they know it'll get taken care of. I mean, it would get taken care of regardless, but I think it makes them feel better.
Yeah, and you know, I don't mind going to those meetings, because it does give me the knowledge I need to take care of the people here, even if it's from a distance. But ultimately, like I said, ultimately the administrator, if something goes wrong, you're going to be notified by a family member. It's just the way it is. because they don't want to talk to anybody that's on the floor or in dietary, or whoever delivered lunch today and flipped it upside down, or, you know, they don't want to talk to those people. They want to talk to the administrator, and they want to know why you have incompetent staff or why you let this stuff happen. And be ready. Be ready. A lot of times the individual calling, though, will listen. Sometimes they don't, but most of them will rationalize and listen. And believe me, you're going to have mistakes. There's going to be mistakes. There's going to be mistakes on all different levels. You just hope you didn't kill anybody.
Own up to those mistakes.
Yeah, for me, integrity, and this is something I want to see in employees in every situation, is that they have integrity. And to me, what that means is I want to know that the person I'm seeing in front of me doing her job is the same person when I'm not around, or when there's no supervision around. They're still performing their job. To me, that's integrity. It's stuff that you would do regardless of who's around. It's not being that person that as soon as a supervisor's gone, you get on your phone and hide in a room. That's not integrity. I want to know that you're honest and that you will tell us when something's wrong, and don't blame it on the next person. If somebody had made a mistake, I want you to own it. And I tell them, we can correct it. I can't correct it. You can't correct it if we don't know there was a problem. So communication is always going to be your big point. You also, I'm really involved with therapy also. We contract it out. You know, we went through a hiring process of who we changed. We have to bid it out every few years. The therapist company that we're using now, we're real happy with. They've been really good. And during the pandemic, we haven't, we've allowed the therapy to come in, but the only reason why is because they have an office here. And we started at the very beginning when the pandemic started that I needed the PT and the OT person who were going to treat to be only going to Spanish Cove. And the company worked with us, and that has happened. So your residents are still getting their therapy, and that's the only way they can get better. If you get a skilled patient, that's the only way they can improve. They're here for that therapy. So we didn't want to shut it down, but we wanted to make sure people were still able to get the care they needed, but limit their contact with people. So even if they're in quarantine, Jackie, or isolation, how do we handle that?
Well, they perform the therapy in the room. They don't come out of the room. They go to the room and do it with the patient until they come out of the 14-day, and then they can go to the therapy room.
And we'll use speech a lot too. So we have a person that comes primarily here for speech. The laboratories and diagnostic and all that's a little different. We draw the lab, and that way we can put it out in an ice pack or whatever we need to do in an ice chest if it requires to be iced down. And they pick it up at the door from us. We'll go get it, and they pick it up at the door, the specimen, and go back to the lab. One thing we have had is radiology out here, and we did have a scare with one of those employees. They were exposed by somebody else. We found out after they had been here. So make sure, thankfully, we didn't get anything out of that. We didn't get any COVID. But that's because everybody was wearing the right protective equipment and protecting. So psychiatric, we don't really have any psychiatric that comes here. But like I said, there's places for you to send them for an eval. And we work closely with hospice. And that's been another sticky point with the pandemic. Your staff, I don't know what county you're in, but when you're the administrator and you're in a pandemic like this where you can't have the visitation, that cuts out your aid visits from hospice, your nursing visits, your chaplain visits, your social worker visits. Those are all things you have to absorb as a staff, and you're already overloaded. So you have to add these extra tasks onto your staff. For me, I hate that. They're busy already. But we just have to take what we can and move on from there. But we're trying to figure out how we could now, since we can allow visitors, how we can let some of those services back in, but still protect our residents and our staff. And some of the hospices that we've talked to do not do any testing on their employees. But we've been able to talk to some of the hospices, and they will test their employees weekly, like we're required, just a couple days prior to coming in to visit a resident. Have we had any of them come in yet? Yeah. Okay.
And then we had another hospice call yesterday. They'll test their employees twice a week if they need to.
Okay. So it's your role to call on these companies and work together so that your staff and your residents can have the quality of care they need. They still need the x-rays. They still need the diagnostic. They still need the hospice. If they went on hospice, there's a reason they went on hospice.
And I did learn from one of our survey team members that just because hospice doesn't have the regulation to test, you have the regulation to test any consultants, contractors, and all that before they come in your building. So it's your job to make sure that they're COVID-free before they come in your building. I know not a lot of other facilities are doing that because hospice told me they're not, but for us, it's our policy, and so hospice will have to follow our policy, and it's our job to make sure they follow our policy so that we don't, get a deficiency because we're not following our own policy.
And transportation, we offer transportation for life care, for independent, for assisted living, and for our skilled and our long-term care. We've always offered transportation to and from doctors. Well, that all stopped, and it came to a sudden halt. And thankfully, Medicare and the other payer sources are allowing for virtual visits from your doctor's offices, and we found that to be real helpful. Actually, I think Medicare is looking at extending that so that in a normal circumstances, we can use more telehealth. Did you hear that? Yeah. So.
And that's how we actually hospice. We did telehealth with hospice for two and a half months to get through their research and stuff. And we are allowing hospice aides in, still just hospice nurses.
Okay. And when we had the pandemic going, did we have any hospice nurses in or evals or anything like that? So if you needed somebody to do a starter care, let's say it's hospice, how did they do that?
I don't know, we were just lucky didn't have any.
Okay. I can't help you there, guys. Let's look at our organizational chart of what you're going to be working with in most facilities or most wherever you're going to work. Either you work for private owned or corporate owned, and you could be run by a board, or you could be like us, and we're not corporate owned, we're not privately owned. We are run by we're a property of Yukon community. We're a public health and a non-for-profit, and we are run by a board. Our board members hire our CEO, and he works directly for the board, and then they hire him to run us. So in between there should be a CEO, and they will be involved a lot of times. Hopefully you'll have a good relationship with them too, because you have to. You just have to, because they're not medical, and they usually come from the finance world or something like that. So they have a great wealth of information. It's just not so much over how the nursing home runs in the medical area. And you're going to have that ability to help them understand why it is you made a certain decision. We do have a medical director. You will have a medical director. They may have an office at your site. Everybody's a little bit different. Ours is off-site, and like Jackie preluded to earlier, most facilities have one doctor that is your medical director and will take care of everybody in your skilled area and in your nursing home. We're a little bit different. These residents, a lot of them will come on over from a different level of care. They want to keep their family doctor or whoever's taking care of them for the last few years, or it could be 50 years. They want to keep that doctor. They have a relationship with that doctor. So we don't automatically switch them to the medical director. Believe me, a lot of times it's much easier to switch to the medical director. Not everybody wants to sign monthly orders or pharmacy recommendations.
Or follow Medicare rules.
And believe it, they get a lot of FYIs on incident reports. They get one every time we have an incident report. So not all doctors are willing to do that. So some of them will say, you need to turn them over to your medical director. And then when hospice comes on board, a lot of them will sign up with the hospice director, so that medications and stuff will be here at a better time. You have your director of nursing. You have your MDS coordinator, your RN, your LPNs, your CMAs, your CNAs. You'll see some ACMAs. Those are advanced certified medication aides. And they can possibly have different job duties depending on what your facility has chosen to make their job description at. They usually have some kind of specialty in gastro or respiratory, and then diabetes and stuff like that. That will depend on your director of nursing. Be sure and go to them. Let them make that decision on how your advanced CMAs operate. Usually they get a little more money than a CMA, but our job duties are a little different. We have LPNs on the floor, and you guys will too, but I don't know how many people they're taking care of in your facility. And you'll need that to all work together. So
We don't use ACMAs here.
yeah.
I just don't feel comfortable with someone with a 2-week course putting insulin in someone's body.
And as a nurse, we both have that judgment. Insulin, even as coming through nursing school, you always learn that two nurses have to make sure you pulled up the right dose. That's how dangerous insulin is. So we don't allow ACMAs to do that, but we will allow them possibly on a respiratory treatment.
Yeah. I may let them, administer a breathing treatment, but it's weird because even given meds through PEG tubes, a lot of CMAs that we have found aren't comfortable doing that. So our nurses administer the meds in the PEG tube.
Yeah. So, but you can understand that ACMA has gone to special training, and they're going to want to use some of those skills. So try to work out what you can, but make sure it's in your job description. A lot of this we have covered. It's just to make sure that just know that every department is connected. Every department is part of your team. Every department Residents are dependent on every one of your departments, whether it's laundry, housekeeping, dietary, social services. We all have a role to play. And that's what keeps them going. And that's what makes your facility a good facility. And nobody wants to go to work somewhere where you have nothing but chaos and backbiting and staff fighting with each other. You need to do your best to just keep it professional, and hopefully your employees can do that so that they're professional on the floor, because you all have to get together just to make this resident happy, or all your residents happy and have the best quality of life. That's our goal. It's not to make them live forever. Our goal is to make them have the best quality of life they have with what they have left. And that will be what I think you guys should set your goal for too. Otherwise, you're going to have a lot of unhappy people, and that makes your job worse. Here's some of the nursing services.
So the nursing are the ones that provide the care with all the ADLs. It all has to be ordered by a physician. You know, even butt paste, you have to have a physician order for. The MDSs have to be done, you know, quarterly. They also have to be done annually. Your MDS person, I actually had mine just do a webinar last week for updates for the October MDS, and I gave them a test so I can show that they're competent in their job, and I keep that in their competency folders, because all of your nursing staff are required to show competency. So I keep those in a separate folder, so when state comes, they asked me last year, they're like, hey, where are your competency checkoffs? I was able to pull those up just real easy. All your nurses, or your nursing staff, are the ones that administer all the medications and treatment, and we're the ones that document it all. We're the ones that monitor for changes. But I'll tell you what, it's usually not the nurses that notice the change in condition, it's your aides. Your aides are the one that are like, hey, so-and-so's not acting right today, can you come check on him? I mean, they're the ones that know the residents the best. We actually have housekeepers that know the residents pretty well too, because they're assigned in the same area, and dietary aides. They'll notice so-and-so chewed her food a little different today, or she chewed it up and then spit it out. So that's where it comes in, where nursing, dietary, housekeeping all have to work together to care for the resident, because they all notice a little bit of different things. But nursing is the one, you know, that documents a lot of that. Nursing is the one that does the care plan. So the care plan is so super important to get right on admit, because that is what your staff is going to follow to care for the resident. So you need to make sure the person doing your care plan, which us is our MDS coordinators, because we have 2 of them and we only have a max of 57 beds. So, you know, that's pretty good to have 2 MDS coordinators for that. So they do the care plans too. But you need to make sure they're competent and they know how to do it. And staff, we make sure our staff is checked off on the knowledge that they know how to access the care plan, because state has asked our aides that before, like, how do you know how to take care of them? Oh, I look at a care plan. Well, can you show me how to access the care plan? So you need to make sure your staff knows how to access it, and it needs to be easy to read, and it needs to be resident centered. Like, it needs to be centered around that resident specifically. So nursing is the one that does that. So the quality of care through the IDT interdisciplinary team, that is where it comes in on Wednesdays when we do our care plan meeting. Care plan meeting, we have Cheryl, myself, the ADON, the MDS coordinators. We have IP if they have an infection, therapy if they're on therapy. We have dietary, we have activities, and we have social services. So we meet every Wednesday. We get all together and we're busy all Wednesday morning. So that is
dietary.
Oh, and dietary, yeah.
And dietary is involved too.
So that's where we, you know, do the weight, the supplements, the BMI. So having a good IDT team helps with the overall quality of care for your resident. Lots of tags. So your DON is to be an RN. She also is supposed to work 40 hours a week as the DON. So that means if I'm the DON, if I need to work a shift on the floor, it's not part of my DON duty to be a charge nurse. If I need to work a shift, I would come in extra. Let's see. Oh, and Medicare does make you have an RN on duty 7 days a week, 8 hours a day, consecutive. It can't be like, oh, this night shift nurse works 6 hours today, and then another nurse works 6 hours in the morning. No, it's 8 consecutive hours. So we do have that. We have 4 staff members that are on the floor as charge nurses that are RNs. And there are exceptions, but there are very few people that have the exception for the DON.
It's usually people who aren't in the city.
Yeah,
Small rural homes. You can get that exception if you file it with Medicare.
It's been our care plan, and that is an actual reg. And like I said, it's a 48-hour care plan on admission, but our policy is 24. So we do a 24 because you must do the med reconciliation when they're admitted anyway. So we might as well do the complete comprehensive care plan so our staff knows how to care for them. The RN, we do complete pain assessments. We do them on admission quarterly, and we do them with any significant change. So we actually have the LPNs collect the meds, like on our pain summary, they'll write how many times the resident had PRNs in the last 3 months, look back period for the MDS, and then the last quarter, and then the RN will complete it. So it's kind of a combined effort. The RN must sign the MDS, like I said, one's an LPN, one's an RN, so the RN signs off for the LPN. And the LPN, they can complete like focused observations. They can't do initial, but like they can screen for pain, which is what ours do, and they do focused observations like their weekly summaries. You can't say that enough about your CNAs and your CMAs. They are the backbone of your organization. It's not your nurses that are out there. I mean, there are nurses that do it. Don't get me wrong, because I do it too, but for the most part, it's your CNAs and CMAs that are putting the residents on the toilet and making sure their bottoms are clean and making sure their showers are done and toenails are clipped and hair is brushed and teeth are done. So make sure you treat them like they are important because they are so important.
And a lot of times they don't feel that on their own.
They don't. I mean, and everybody, so we noticed with a lot of our staff, not everybody likes to hear a good job the same way. So our corporate complaint nurse, she made up a little questionnaire on how do you want to be shown appreciation and what are your favorite things to be shown appreciation. We were surprised, like we thought like a thank you or food, well, they all hate that. They all want, you know, extra pay or a day off, administrative day off with pay. Some of them, you know, some of them were like food is great or just telling me good job is great, but the younger ones, they want gift cards and stuff like that. So everybody's different on how they want you to appreciate them.
And as the administrator, that's kind of hard to do. You don't always have the money for that extra stuff. So we try to do appreciation as often as we can. We've been better about it during the pandemic. Jackie and Eric, our dietary boss, they always get together and even though on those things you had them fill out, they still like food, but that's just not the way they want to be thanked, I guess. But we will do, Jackie's done all kinds of things like bring Chick-fil-A to a different shift or pizza or sandwiches or just hamburgers.
And we do, during Nurses Week, I had asked dietary to make my nurses like an iced coffee, and everybody liked it. So now we do that monthly.
For all employees.
For all employees, not just nursing. But I show my nurses appreciation all the time, not just my nurses. When I say nurses, I mean my nursing team.
Yeah.
Because to me, you can't have a nurse without a CNA and a CMA. So in Nurses Week, we did everybody together because it builds a better team if you show everybody appreciation at the same time. So that way people don't feel like one is more important than the other. But we did something every day, big things, and then we just gave our staff facility-wide, not just nursing, appreciation bags with like kettle pot popcorn and all these goodies and a cup and they work they can to make sure they're appreciated because we know good CNAs are not easy to find.
And as far as pay,
Cheryl, I don't know if you can hear us, but you're frozen on the screen. Is that what everybody else is seeing, that Cheryl's frozen?
Yeah, same here.
All right, there you're back.
Same.
You're
Hey.
frozen a little bit.
what, Z?
Yeah, the last 30 seconds or so, you were frozen. We couldn't hear anything you said the last 30 seconds.
Okay, so we were just still talking about appreciation. Jackie said that we did, recently we did a Spanish Cove gingham bag and put goodies in it like big bag of kettle corn, some Pringles. Just every department chipped in and we made it for every employee here. And everybody got one of those. It had a Spanish Cove mask in it that you could wear after hours. Of course, not in the nursing home. And it had a coffee mug. It had a coffee mug. It was just a little appreciation. And we try to do that every so often. We're trying to be better about that. Of course, the money is the main thing. You've got to find the money to spend on that. But if every department chips in, it works out a little bit better. And you don't have the animosity between staff. What we found is we always celebrated Nursing Day and Nursing Assistance Day. We usually do them together, like Jackie said. But you know how many housekeepers would come up and say, well, I want some, or why don't they do this for me? And so that bothers me. I don't want anybody to feel left out. So we still do nurses assistants and we still do nursing week because that is special. But the other department heads, it's up to them what they do for their staff. But now we've gone to frequency on doing the whole staff. You'd be surprised how much they need right now just to get up and go. It's just been really hard.
And we're wondering how other facilities are getting staff in the door because the pay is so different. Like we get applicants in here for CNAs wanting, 13, 15, 14 an hour. But I know that our CFO, she was on a call this week with Leading Age, and she said that most facilities are only paying $11.50 an hour. And
That's not true.
I mean, if it is, tell us because, man, we're, these aides that are coming in here to apply are telling us completely different.
Because we're going to get into staffing more. Let's get through this restorative. We talked about restorative nursing earlier, and it's a maintenance therapy, and it's really good for the residents coming off of PT or occupational therapy, because that way you can have a nursing staff who continues to work with the resident. They always have to get their plan of care from the therapist. They plan it together, and it's always not above what the restorative nursing can do. So if we just had for balance and for strengthening exercises is what they were doing PT for, we can continue with those daily things that will make them stronger, keep them ambulating, keep their range of motion good. I think it's a pretty successful area. Now you can't use it in assisted living or anywhere else. It's only a long-term care skilled option. But I find it keeps residents stronger from their therapy, because what we'll see in long-term care especially is people coming on and off therapy because Medicare will only pay for it for so long, and to see some progress, and then they plateau. They get to where they're going to be, and your restorative aide can step in and that resident continue those exercises and help maintain that strength that the resident has gotten. You think, Jackie? Now we're going to get into the nightmare. I don't know, like I said, I don't know how many of you are working in a healthcare facility now, but we talked about staffing earlier this morning. It's a continuing, overwhelming job for anybody to have to continuously have new staff rolling in because staff are walking out or staff are wanting to collect unemployment or
I'm just done with nursing.
we're getting a lot of burnout. I don't know if you guys are seeing that yet where you're at, but it's been very stressful. And not everybody is able to cope with that. And they can go to Hobby Lobby and make $15 an hour. They increased it. And you can go to those Target and Hobby Lobby and Amazon, all those places are going to pay you more, or at least equivalent to what we're paying or what you're paying. It's hard to compete with that because here you have to deal with billings, you have to deal with physical labor, you have to deal with mental problems. So it's just very overwhelming job. And to try to get new staff in, if anybody's got any great ideas out there, type them in. Anybody with any ideas on hiring, because we used to not have any problem with staffing. It kind of hit us during the pandemic, where I understand it hit some of the other places way before then. And I always think that's because you're doing a big job. These CNAs are doing a huge job for you and for your facility. And maybe they deserve probably $25 an hour, but nobody can pay that. You can't pay them more than you do your nurse. So it's a pretty overwhelming feeling. But you are required to have staff or you'll get tagged. You got to have sufficient nursing. You got to have staff. You got to have a certain amount to care for your residents. They don't give you a ratio anymore, but you got to, you see this on your 5-star rating. Staffing is another big issue on there. It's the RN hours, it's the LPN hours, it's the coverage. How many hours you spend with a resident a day?
On the QOC, you're not allowed to go below 2.7, and I know that now there's several facilities that are having issues with that. We are not. We are still overstaffed according to standards that other homes use, but our residents are spoiled.
We don't feel like it.
We don't feel like it. Our residents are extremely spoiled. We're a standalone facility. They pay us to spoil them. So they want us to have the extra staffing, but we just can't replace people that we're losing, and we just don't get it.
So at the end, I'm going to give you my email, and that way you can email me any questions you have, anything to add to comments, any ideas for other people. It's just the way it is. I want to know more knowledge. I've still got growing to do. So you can see that staffing is giving your DONs a headache, probably you a headache. It's just not fun right now as far as staffing goes. Jackie has to post every day at the beginning of each shift, the facility name, the current date, the staffing that you're going to have that day, and if they're licensed or unlicensed nursing staff, and resident census.
Yeah, so I post that in the hallway by the ADON's office, but I also post it at each nurse's desk. So if the resident wants to look at it or the family wants to look at it, they can. Yeah, and so you have to look at the acuity of the residents that you're taking care of, because I know for a fact, sometimes the people that walk and talk and have dementia, it takes so much more staff to take care of them and corral them than people that are bedbound. Because people that are bedbound, yes, you're gonna use 2 people for the assist, but people that have dementia, you're gonna use everybody trying to keep them from getting out the door. That's just been my experience. It just takes a lot more to take care of a dementia person, not physically, but man, they run everywhere trying to get out everywhere. And you do have residents and families in the ombudsman, they often ask us in care plans, like, what's your staffing ratio, or new potential people that want to move in here. That's one of the first questions they ask our marketer is, what is your staffing like? And so I often report my QOC hours or whatever to our marketer, so she knows kind of what our staffing ratios are. So the DON really needs to keep track of that. I also pull call out times. We have a call out system that makes no sound except at the nurse's desk, on like a little, I don't know, it's like a board that just lights up. It's not an old fashioned board, it's just like a kiosk. I'm gonna light up what room. So that way the residents don't hear it and they're not overwhelmed by it. So I pull up those call out times because it's connected to me, and I monitor those frequently. We don't like any call outs over 5 minutes. So if there's a trend and it's over 5 minutes, I'm going to the staff and asking what's going on. And I do notice trends. Like, we used to have a resident, I noticed she every day, it was the exact same times her call outs would go up. So I developed a plan with the staff to be proactive rather than reactive, because they're like, she always pulls the call out right when we're trying to get people fed or get the trays out. Well, you know she's going to pull it, so let's go ahead and toilet her at these times, so that way you're cutting it off before she pulls the call out. So I monitor the call outs and stuff. And if we do have changes in condition and we bring more staff on, that's where right now not being able to hire anybody, that's going to present a problem. I'll pull nurses to the floor is what I would have to do, because right now I have 3 nurses for 28 people. And we don't have very high acuity. You just happen to be lucky right now with nurses. So I would pull one of them to the floor. So that's another thing is, as administrator, I think you would need to know if you're at a staffing crisis level that you need to be pulling people. And yes, I'm willing to help out wherever. I serve trays, I do showers.
Do you guys have ideas or experience of what's working for some people as far as hiring and keeping employees? If you do, put them in the chat box. Consistent staffing. We try to always give consistent. We try to make consistent staffing because it's best for the resident caregiver. You have some people that want to work memory care, and that's great, but in our long-term care area, it's just long-term care altogether. So your memory is all together with it, and not everybody can handle that mental status problem, and they just can't. They don't want to do it every day. Let's say they work 5 days a week, 8 hours. They don't want to need a break. So you do the best you can with what you have.
I have a staff member right now, she works night shift, and she works on the second floor, which is very, very, very quiet at night. She came to me and she's like, I'm so bored. I have been up here for 8 weeks. Is there any way you can switch me downstairs? So make sure, you know, when your aides are telling you they're burned out, you need to switch it up.
Yeah, and you guys need to listen to your DON and your staff. I mean, you got to figure out what's the best thing. Is it going to be detrimental to the resident if you have to change the caregiver, or will it be okay? And thankfully here, almost everybody knows everybody. So it's not really a big problem here, but you're going to have, every once in a while, you're going to have that one resident that clings to somebody. And that person's very important in their daily life.
So we do try to accommodate that.
Yeah. Okay, I think we talked about the partnership a lot.
our relationship with our medical director, like, we have his cell phone. We text him all the time. He tends to listen to Cheryl more. I can text him all I want, and he lets me pretty much, make my decisions and run through him and stuff. But if I need something, I have to go to Cheryl because she will get in and he'll get me stuff immediately after she talks to him. So sometimes that's where, you need the heavy hand and she needs to get on him to get us our stuff.
It's hard to get on the doctors. They think they know everything, right? And the medical director that we have found, he's really a great guy. He's nurse friendly. That's the one positive thing about, there's lots of positive things with our medical director, but that's the main thing that I love about it, is he knows your nurses are frontline. He knows your aides are frontline. He's going to listen to them. He may see that resident once every 2 weeks, and it may be telehealth, it may be in person, but he listens to the nursing staff and he's somewhat accurate, and he gives us a little bit of rope to hang ourselves with. But he's actually married to an RN, so he doesn't really have a choice. But he is valuable in that part. He's valuable with our residents. Make sure you have someone who can get along with the residents, not somebody that goes in and lectures them or gives them a whole story about what this medicine's going to do. The residents don't usually want to know that.
So like our medical director before this one, he refused to medicate for pain. And I'm sorry.
That was unacceptable.
When you're old, you hurt. And when your residents actually see a psych doctor, your medical director should never mess with those psychotropic. But he would take them off of them, and residents would have, behaviors, like really bad behaviors. And so we finally found a medical director that is pain med friendly. He will let us do psychotropics if we have tried everything else and we absolutely need him to get him over a hump.
But we don't like to use them.
And he doesn't like us to use them long term either because they, increase your falls. But we've found a happy medium. As long as I, as a nurse and as a human being, can find someone that will medicate these people for pain when they need it, that makes me happy. Because when they say they hurt, we have to listen to them.
At one time it was so important because pain was your 5th vital sign. And then the overuse of opiates got blasted out in the news. And, for a nursing home, I don't think that should pertain. These people lived a whole life. They hurt just sitting up in bed or getting out of bed. So, of course, many of them don't want to use anything for pain. We have a lot that use Tylenol, but you also have a lot of back problems at this stage. And they just ache sitting everywhere. And we start with the lowest dose of something. We'll start with Tylenol. Ibuprofen's not a big one because it hurts their stomach. But don't ever just knock them out. We want them to be on the lowest dose possible and function. So you have to be real careful with it, and hopefully you'll have a medical director that will sit down and talk to you and talk to the resident and find out where we need to be. We take our leadership from the medical director on that. And when we didn't have anybody that would treat pain, that was awful for the residents. And we had a lot of people rebounding with pain. We had a lot of people rebounding from not having their psych meds. Because you do have to follow GDR, the gradual dose reduction program. So it's a fine line, and all this stuff we're talking about today will be an indicator, a quality indicator on how your facility is, whether it's a 5-star, whether it's a 4-star. It's not how pretty your facility is, it's how you run. So you want it to be clean, of course, but you gotta know what's going on, and you've got to know what your quality indicators are. That's why that Casper that I go to with the nursing staff is important, because that's going to tell you where you are and where you could improve your 5-star rating, where you've got room for growth, things you need to correct. you will find all that information in there. And if you're not a nurse, that's great, because you need to know this. You need to know what you can do to make your facility be one of the top facilities in the state. And I think that's what we all strive for. First off, we strive for resident care and happiness, and for them to live a long, healthy life and enjoy it. You don't want them just to be in bed all day and not enjoy things. So you got to make sure your facilities are running the best you can, and know what it is you guys can improve on. I mean, several of you may be 5 stars, but there's always room for improvement. Nobody's perfect, and you will have flub ups that you'll have to cover. Jackie covered this kind of earlier. It's her role as the director. She's always on the floor. We all try to go to different departments. Well, I try to go to different departments and make sure everything's running correctly, make sure they don't need my help with anything or don't have any problems. I don't know if that's because I'm nosy.
Well, I help other departments too. So like if Eric has an issue that he thinks I can help, he's our dietary and housekeeping, I help him. I help the director of nursing and AL with some of her stuff. You just want a director of nursing that will help everybody. Like, I know I have the largest department. I know my department is the most scrutinized as well, but you want to be able to have a good relationship and help wherever. And my employees, believe me, I have an open door policy, and they are not afraid to ask me for anything. You definitely want to try to push your staff, the ones that you think will want to seek educational opportunities. Like, we try to make our offer CMA school or stuff like that. We have scholarships. We try to have our staff do. I put staff through restorative training. So you just want them to know how important they are to you. I know all my staff by names. I know their kids' names. I'm not friends with any of them outside of work, but I do know their personal lives because they feel like I am part of theirs, so they come and share it with me all the time.
Yeah. Sometimes they just need to get something off their chest.
And definitely, I have high standards. I have very high standards just because I started here as an LPN, so I've done the job. And our residents have high standards. Their families have high standards. So sometimes staff do find it difficult to work for me because they can't rise to those standards, and sometimes those staff don't last long because you have to treat residents a certain way. You can't be mean to residents in any way or cross, or if a resident asking you to pick a tissue up off the floor 5 times irritates you, this is probably not the job for you. So,
or if they pull their call light because they can't change their remote,
and you know, want to roll your eyes and be like, I'm not going to get that. That doesn't work for me. Documentation, yeah, for sure. If it wasn't documented, it wasn't done. You can't later go back and do it. That's false documentation. And here you can be terminated for that. Our medical records person is an actual nurse as well. And she goes through those and she gives documentation errors every 2 weeks. She writes down all the blanks and gives those to the staff. We've actually had our lawyers come out and do a training on what it's going to be like if you were caught without your documentation. And he looked at some of our charts, and spelling was a huge thing. Like, there were so many misspelled words, it was insane. And you can't.
EMR has a spell check.
Yeah. Yeah, our EHR has a spell check, so there's no reason to ever misspell it. Also, abbreviations, you need to make sure, the DON needs to make sure there's an approved list of abbreviations that your staff can use. And I mean, you can't use the ASS period for shortening assessment. I mean, that just looks bad in your charts. And the staff must be educated, and they need to be working like in their scope of practice. So when they document, an LPN is not supposed to do an initial assessment. So they need to use the proper wording in their documentation, like they evaluated or they screened or, you know, something like that. They can't, I mean, there's only certain things your LPNs can do in their role. And always, like, we ask our nurses to document as they go throughout the day. There's no reason our nurses can't. We have kiosks all over the place, so they can turn around and do it pretty quickly. Our CNAs and our CMAs also use our EHR, and they all document well in it too. Our EHR, of course, times and dates everything automatically. I kind of already went over that. Oh, and we tell our nurses all the time, you didn't document this or you didn't document that, and they'll say, well, I did it. And we always tell them, give yourself credit for what you did do.
Because believe me, they do a lot more than what's documented
Yeah,
for
they
that
do.
resident.
And so, and also you want to make sure your nurses know to document like the changes in condition and that they've notified families and that, you know, everybody is involved in the whatever happened with the change of condition, the physician, the family, the POA, the resident, the DON. My name's charted all over in those charts.
And as an administrator, the way you're going to evaluate your team is that you're going to look at the last 3 surveys. You're required to have those surveys posted up front in the front of your facility when they come in so that anybody can have access to them. We don't hide them. You're not allowed to hide them. They're all over the internet anyway. And so we always keep a big red book up front that says for surveys, and anybody can pick that up or ask for it. It's just right up front. It's a book they may not look for, but I'm always involved in the surveys anyway, so I always know what the end looks like, and if we've got our corrections done and plan of care done to send to the state. So you've got to know that. You've got to be aware of what's going on. And the surveys are really important because you've got a timeline that you have to, if you get a deficiency, to correct that. And for them to come back out and reassess to make sure you did correct it. So once you get those deficiencies, you'll be real familiar with that process. Like I said, I always look at the quality indicators. That's in your Casper, and that's what we look at every quarter. If we need to, my quality improvement nurse will always give us a heads up. That's going to affect that. That's going to affect this, and make our plan from there. We do satisfaction surveys. We try to do them annually for the resident and the families, and then employee. I'd say we try to do those often because right now that's just something we got to focus on. I don't know about anybody else's census, but this last 6 months has been hell. We're just not seeing any referrals from the hospital, or, you know, it's just all down. So I hope that wherever you're at, that you guys are surviving and doing comfortable and seeing some admissions. I mean, with something we've seen a huge decrease in. And it'll be time spurts where you won't get any calls from the hospital. So you call and remind them, hey, I'm taking referrals. And then you may get a few, and then it just dies down again. It's just not there right now. We always look at turnover, always. Turnover, I don't think so much means the same thing it used to. It's more prevalent now. People take less ownership of their job. I don't know if it's the generation thing. I just don't know. I have to listen to families and residents, their grievances, their complaints, try to work those out. I always review the resident council minutes from your long-term care area. They meet monthly.
And I address anything nursing related and write a statement and give it to the person that runs the council. So that it's addressed. And if there's any, thing that I can do about the resident council complaint, then I will fix it.
And this is for every department. Every department, if they get a complaint from a resident in one of their council meetings, it goes to that department. They try to answer it the best they can for the resident or for the council. Sometimes we don't know who the resident is, and that's okay. But we want to fix the problem, so we make sure we do that. And of course, the ombudsman, we've told you about the ombudsman. The capabilities of working the electronic health record. Jackie's been referring to it as the electronic medical record. You can go either way on that. And the one important thing in your facility is make sure you're up, walking around, looking around. You can listen. A lot of times the residents will tell you something they may not want to tell the staff. And also tour with your nose, as they will tell you. Make sure the smell, you don't have a urine smell. You don't have any musty smells in your facility. Here's the resources that you have. My best resources are usually through Leading Age. We're a member there, or the health department, but my best references are my staff and my department heads. They've all been doing it long enough that we can help each other, and they have a great amount of knowledge. So if there's a problem, we just go through it and try to work it out and solve it. We'll call the people that we think might be helpful if it's to answer a question. So I hope you guys are looking forward to your job. It's a big one. It's a big shoes to fill. But it is a privilege. It gives me opportunity to spend time with people and try to make their life great. Who cannot go home and feel good about that? That's why I do it. I love people, but I want to make sure these people are getting the care they deserve. I hope that's your goal too. I hope your goal is to make them happy, help them have the best life they have left, and quality over quantity. Does anybody have any questions? Okay, I'm going to give you my email. I'll write it down in here on chat. Did it go through?
Yes, it's on there.
Okay, I see it. I'm looking through the chat board to see what we've missed. Yes, a CMA can't give B12 shots. An advanced CMA can give one if that's what they're trained to do. They all have special, some of them just got the gastro, some of them just got the respiratory, some of them got everything. So on your CMAs, your advanced CMAs, you have to look and see what they're advanced in. And always, always, always do your skills checklist.
You have to write policies for it too. If
Yeah.
you're going to let your ACMA do anything in your building, you have to write a policy for that. I don't have any policies because I don't let them do anything.
Okay, I have another question.
Okay.
One of the facilities I work at, they allow the CMAs to give liquid morphine if it's scheduled, the sublingual one.
Yeah. We allow that too.
You do? Because I know as a nurse, I don't feel comfortable at times giving it to them. So I know, like some of them have told me that some classes for the CMAs 2 to 6 weeks, depending on where you go.
Yeah, that is true, but they are the ones counting the cart. They're the ones counting that medication.
They can't hand it over to the LPN to give.
Yeah.
That's not allowed.
So, I mean, here, that's not allowed. I don't know how other facilities do it, but our CMAs have been trained and they know. I've had the same CMAs for the whole 15 years I've been here, most of them, but I mean, it also depends maybe on what your DON is comfortable with or what your facility policies are, but most CMAs give liquid morphine and the liquid Ativan.
All right, thank you.
Does anybody work in a long-term care facility that's comfortable sharing what they start CNAs out at?
I've had some really good ones that have been CNA for like 5 years and they make 11 something an hour.
Where is that at? Is that in Royal or like in the city?
The city and in Norman.
Wow.
And they accept that? They accept 11 an hour?
I told them that there's some other places where they can get better pay, but they're really good CMAs. So I try to help them out whenever I can.
Absolutely. You want to keep those people. They're jewels in your crown. I see a 1050 on here. So not everybody, it seems, is there for the money, but
I think that's what we are. They're the bottom one, 11 and 13.
we try to stay between 11 and 13 depending on their experience as a CNA. And I don't know if we have our long-term people top that for sure, because in the past they've had an increase every year for job performance, as long as they're still doing a good job. We do evaluations every year. It's important for them to get feedback. It's important for you to hear their feedback. So Jackie does her raise interviews.
I'm
And
really different than a lot of other department heads because I actually do evaluate you. Like I don't automatically give you the allotted raise that our board, like if our board said everybody gets a 3%, not everybody gets a 3%. If you're continually late or you call in, that's part of your evaluation that I give you. I'm fair, but the residents deserve what they pay for. So our CNAs may not all get their 3% raise, but they have an opportunity. I let them try to improve for 90 days. And if they improve, I'll give them that extra % that they didn't get.
anybody else?
So on these ones that are starting at like 1250 or whatever, do you guys have shift diff too? I mean, is that your base pay plus you have shift diff?
Okay, you're not sure about that. Okay, I know we used to pay shift diff. We took that away and increased the base salary. So because I never understood shift diff as far as nursing and stuff goes, the hardest shift of the day is day shift. They get the baths, they get the meals, 2 meals a day. And the night shift's the one that always get the highest amount on shift diff. So I never quite, even as a nurse, figured that out. So
we don't have a problem keeping night shift here. So they decided to just roll it all in to increase the base pay and take shift diff away.
well, I hope you guys get finished with school, and I hope you land on your feet and get a great job. I find it makes me get up every day. I love what I do. I love our people. I love our employees. And I don't know what I'd do without my job. I wasn't sure about the role when I first started, but I've been in it for several years now. And it's a big job, but it's something you guys can do. How are you doing in-services stuff? On in-services, we've recently went over to Relias Services.
By recently, she means 2.5, 3 years
Yeah.
ago.
And I don't care for it so much during this time, during the pandemic. It's good. I like to have in-person meetings so that you are in front of your employees. Your director of nursing is in front of your employees. I find that's more personal, and that's what I like. And I find you have a better relationship with your staff. Ever since we've gone to the online stuff, it's really kind of separated. So it's not as good interpersonal. So yeah, Terry, we try to do in-person ones too.
We do, before this started, we did do a monthly nurses meeting, third Thursday of every month,
But I do think a lot of people are getting their in-services in online better than always having to come up here every 2 weeks and doing one in person, because kids, the school's out, different times now with the COVID, and night shift hates it because they're always having to get up during their night to come to a meeting. So it has worked out well, just like for you, Terry.
I'm gonna put my email in here too if anybody has any questions.
Okay, Jackie just put her email in too. You can send us, if you have a question, a statement, anything that you would help the whole congregation, just send it away. We'll do our best to take care of it. And you guys have a great rest of the day.